Welcome to Bookfulness, the deep dive dedicated to navigating the foundational texts of medical science. This is episode 1, The True Zero Point, and we are starting with the language of life itself.
Exactly. And our mission today, it's foundational, yes, but absolutely crucial for every single step you take later in healthcare. We're essentially establishing the core language, the structural understanding you need for human anatomy. We're diving straight into Chapter 1, Overview and Basic Concepts. Specifically, pages 87 through 130 of Moore's Clinically Oriented Anatomy.
That's right. And for you, our learner, maybe you're prepping for your first anatomy session or a big lecture, or maybe even that first time in the dissection lab. This stuff, it's the indispensable vocabulary. If you can't speak this language, you really can't communicate precisely about a patient's condition, their diagnosis, or the treatment plan. Not accurately, not anywhere in the world.
Yeah, think of this deep dive as maybe the shortcut to avoiding a lot of confusion down the line. We're trying to turn what could be, let's face it, a vocabulary flashcard nightmare into a coherent, organized map of the human body.
Okay, I like that. A map. Let's unpack this foundational chapter then. Starting with section 1. Approaches to studying anatomy. How do we actually, organize this mountain of information?
Okay, first things first, we need to define the scope. We're focused here on gross anatomy.
Gross anatomy.
Which just means the examination of body structures that are large enough to be seen without needing a microscope, the big stuff.
Got it.
And the material, Moore's, outlines 3 distinct ways we can organize this knowledge. Each one reflects a slightly different learning goal or maybe a clinical goal.
Okay, 3 ways. What's the first one? I think the text mentions it's the main one used in the book itself.
Yeah, that's regional anatomy. It's also called topographical anatomy. And it's the primary approach used in this textbook and honestly in most dissection labs too.
Regional or topographical. So it organizes the body by location.
Exactly.
Yeah.
Strictly by location. It focuses on specific segments or parts like the upper limb or the thorax or the head. The major body parts shown in figure 1.1 in the text.
And the real power of that regional approach, I guess, comes from learning the body not just piece by piece, but layer by layer, like how you'd encounter it in dissection.
Precisely. That's the key. It mirrors dissection. You examine the structure sequentially just as you find them. You start with the skin, then you go deeper to the subcutaneous tissue, then the deep fascia,
Right.
moving into the deeper things like muscles, the skeleton, and finally you get to the cavities that hold the viscera, the internal organs. So the regional approach really forces you to understand the spatial relationships. How does this nerve relate to the blood vessel right next to it and the muscle it supplies? It's all about context in that specific area.
Okay, that makes sense for dissection. But I worry if we spend all our time in the lab just focused on, say, the forearm, do we risk forgetting how that forearm connects to the whole arm or even the central nervous system? How does the text handle that potential downside?
That's a really valid point. It's a critical challenge of purely regional learning. But the text is quite explicit about this. It mandates that even when you're studying a single region, you must routinely put that anatomy back into context.
Okay.
Think about adjacent regions. Think about the body as a whole. Because, no structure exists in a vacuum. For instance, you can't fully grasp the brachial plexus, that big nerve network in the axillary fossa, the armpit,
Right, the axillary fossa.
without understanding how it contributes nerves to the entire upper limb. You have to connect it outwards.
Okay, so regional gives us the local detail. What's the second approach? Does that give us the bigger picture?
Yes, the second approach is systemic anatomy. And this one seems to provide that broader integration you're talking about, precisely because it focuses on function.
Function, right, like organ systems.
Exactly. Systemic anatomy organizes everything based on the body's functions, looking at the 11 major organ systems. We cover, everything from the integumentary system, that's the skin,
Okay.
to the skeletal, articular, joints, muscular, nervous, circulatory, digestive, respiratory, urinary, reproductive, and finally the endocrine systems, all 11.
Let's maybe zoom in on one of those for a second. The circulatory system. The text makes an interesting distinction there, doesn't it? It's not just one system.
Yeah, that's a great point, yes. The circulatory system is actually presented as 2 parallel transport systems working together. First, you have the cardiovascular system.
Heart and blood vessels.
Right. The heart, the arteries, the veins, propelling blood, delivering oxygen and nutrients, removing waste, the classic circulation stuff. But running right alongside it, and absolutely essential, is the lymphatic system.
Ah, the lymphatic system.
Yeah.
Yeah, that often feels a bit secondary until, like you said, something goes wrong clinically.
It's really fascinating, though. The lymphatic system is this specialized network of vessels. Its job is to withdraw excess tissue fluid, we call that fluid lymph, from the space between the cells, the interstitial space.
Okay.
Then it filters that lymph through lymph nodes, which are crucial for immune responses, and eventually it returns the cleaned fluid back to the bloodstream. It's vital for maintaining fluid balance.
And when it fails?
Exactly. When this system fails, maybe after certain surgeries where nodes are removed or due to infections, you can get lymphedema. That's that chronic, sometimes debilitating swelling. It often needs intensive management, maybe with compression garments. So understanding its systemic function is absolutely key to recognizing that failure.
So we've got structure, the regional approach, and function, the systemic approach. That brings us to the third one, clinical or applied anatomy. This sounds like where the rubber meets the road, where the first two have to merge.
Precisely. This is the problem-solving domain, and it requires what the text calls the inverted thought process.
Inverted thought process.
Yeah. When you're learning regionally or systemically, you typically study a structure and ask, okay, what does this do? What's its action?
Right.
Clinical anatomy flips that completely. You start with the patient's symptoms or something you observe, a manifestation.
So instead of starting with the normal, we start with the abnormal, the problem. Can you give a concrete example of that inversion?
Sure. Let's say you're learning about the common fibular nerve,
Hmm.
maybe systemically. You learn it supplies the muscles that dorsiflex the foot, lift the foot up.
Okay.
Now, clinically, a patient walks in with foot drop. They can't lift their foot properly when they walk, it just drags.
Right, I've seen that.
So your clinical anatomy question immediately becomes, okay, foot drop is the result of not being able to dorsiflex, a lesion, an injury to which nerve would cause this specific problem. You work backward from the symptom.
Ah, okay.
And in this case, that backward reasoning would likely point you to a compression or injury of that common fibular nerve, maybe where it wraps around the neck of the fibula bone. It's connecting symptom to structure.
That diagnostic mindset, working backward, that's really the ultimate goal of studying anatomy, isn't it? Which is why looking at the living body, using imaging and surface anatomy is so critical. It's not just about the cadaver.
Absolutely. The text makes a very strong point here. The cadaver is static. It lacks muscle tone. It doesn't have body fluids under pressure. There are no internal pressures. And critically, none of the constant effects of gravity that affect organ position.
So surface anatomy.
Surface anatomy lets us visualize those deeper living structures through physical examination, palpation, feeling structures, observation, listening with a stethoscope, auscultation. It connects the outside to the inside in a living person.
And then technology lets us actually peer inside that living body.
Exactly. That's where radiographic anatomy comes in. Using techniques like X-rays, CT scans, MRIs, this gives us crucial info about normal structures in living people. And importantly, it reveals the effects of trauma, pathology, disease, and aging in a way that dissection alone just can't show. We rely heavily on sectional imaging, those slices you see on CTs and MRIs, to really understand the relationships of structures cut along different planes, like transverse or sagittal planes.
And there are even more specialized ways of looking inside, right? Especially thinking about joints, maybe.
Oh, definitely. Think about endoscopy. This isn't just a general scan. It uses a flexible fiber optic device, a scope, inserted either through a natural opening like the mouth or through a small surgical incision, a portal.
Like keyhole surgery.
Sort of, yeah. An arthroscope, for example, is put directly into a joint cavity, like the knee. It allows a surgeon to directly view the living cartilage, the meniscus, the lining of the joint, the synovial membrane, and often they can perform minor repairs right then and there.
Wow.
That real-time, high-definition view of internal structures in a living, moving body, that's maybe the ultimate application of clinical anatomy.
Before we jump into the specific terminology, the nitty-gritty language, the text highlights a really critical modern distinction, one that's essential for patient care: the difference between sex and gender.
Yes, and this distinction is absolutely non-negotiable today. For providing empathetic care, for taking an accurate medical history. It starts with understanding the terms. Sex, typically male or female, is assigned genetically based on chromosomes.
XX and XY.
Right. Females typically carry 46 chromosomes, including 2 X chromosomes, XX. Males typically carry 46, including an X and a Y, XY. And the material does note that genetic variations exist, like Klinefelter syndrome, XXY, or Jacob syndrome, XYY.
But that biological definition, the genetics, that's separate from how someone identifies.
Correct. Gender identity is distinct. It's an individual's intrinsic internal sense of their own gender, And importantly, it exists across a spectrum. It may or may not align with their assigned genetic sex.
And how someone expresses that identity can vary too.
Absolutely. It might be expressed outwardly through appearance, personality, behavior, or it might not be outwardly expressed at all. It's internal.
So why is making this distinction so central in a clinical anatomy context?
Well, the clinical relevance is really twofold. First, and maybe most importantly, it's essential for building a trusting relationship with patients. Asking about preferred pronouns, acknowledging someone's identity, that's just basic respectful care.
Makes sense.
Second, there can be physiological considerations. If a patient is undergoing hormonal transition, for example, there are physiological risk factors for certain conditions. Things like cardiovascular health or osteoporosis risk might change. They might require different screening or assessment protocols than those typically associated only with their genetic sex. And the text also defines gender dysphoria. That's the significant distress that can arise from a mismatch between someone's gender identity and their assigned sex. Clinicians need to be aware of this and approach it with sensitivity.
That clarity is crucial. Okay, that perfectly sets the stage. We've got the subject gross anatomy and the approach is regional, systemic, clinical. Let's move to section 2, anatomic medical terminology. We absolutely have to learn the standard language.
We really do. The need for a shared, precise language just transcends borders. Anatomical terminology forms a huge chunk of global medical communication. We have to get rid of the ambiguity that comes from using local colloquial terms.
Right. So step 1 is committing to standardization. Even if the formal terms feel a bit, well, clunky at first, we swap the common name for the official one?
Absolutely. No more armpit. From now on, it's the axillary fossa.
Axillary fossa. Got it.
No more collarbone. It's the clavicle. This kind of rigorous standardization follows the international standard, the Terminologia Anatomica. It's the internationally agreed-upon anatomical nomenclature established back in 1998 by the IFAA, that's the International Federation of Associations of Anatomists.
Okay, so we use the official terms, but I noticed the text still includes some of the older terms, the ones named after people, eponyms.
Yes, that's a deliberate pedagogical choice. Eponyms terms named after people, like the sternal angle, which you'll often hear called the angle of Louis, they're technically not endorsed by the official international terminology, the IFAA. But Moores includes them in parentheses throughout the book. Why? Because they are absolutely entrenched in clinical practice.
Right.
You will hear surgeons, nurses, older physicians using these terms, and you need to recognize them to function effectively day to day in a hospital or clinic. So learn the official term, but recognize the common eponym.
Good advice. Okay, before we can even define a single location on the body, we need the universal reference point, the anatomical position. I sometimes see students kind of gloss over the details of this, even though it seems simple.
It's foundational. It is the rigid, non-negotiable baseline. All descriptions of location, anterior, superior, medial, whatever, originate from and relate back to this specific position. If a structure is described as anterior, it means anterior relative to this position.
So what are the specific components? There are 4 key elements, right?
4 elements you absolutely have to visualize and be able to articulate precisely. First, the person is standing in an erect stance, upright.
Okay, standing straight.
Second, the head and the gaze are directed straight ahead, not looking down, not looking up, straight forward.
Got it.
Third, the arms are hanging adjacent to the sides with the palms facing anteriorly. Forward.
Ah, palms forward. That's the one that's easy to forget, but it's crucial, isn't it? It affects how we describe the forearm bones.
It's absolutely crucial.
Wow.
It dictates the relative position of the radius and ulna in the forearm, which is essential for understanding movements like pronation and supination later on. So palms face forward.
Okay, palms forward. And the last bit.
Fourth, the lower limbs are close together with the feet parallel and toes pointing forward.
Feet parallel. Okay. Erect, gaze forward, arms by sides, palms forward, feet parallel. That's the anatomical position.
That's it. And we have to apply one important caveat the text mentions: gravity.
Ah, right. This position assumes someone's standing up.
Exactly. When you're standing, gravity pulls things downward. Internal organs, the viscera, they shift down a bit. But patients are most often examined supine, lying on their back.
So descriptions might differ.
They might. So if you're describing an organ's position based on how it lies when the patient is supine, you have to specifically note that in the supine position, the liver edge is, because the default, the standard reference, is always the erect anatomical position unless stated otherwise.
Good point. Okay, position established. Now we need to talk about slicing and dicing this body model conceptually, of course. planes and sections. This is so important because every medical image we look at, whether it's a photo from a dissection, a histology slide, an MRI scan, it's based on this idea of planes.
Absolutely. We use anatomical planes to describe the relationship of any part of the body to the whole and also to create those images. There are 4 standard planes you need to know.
Okay, let's start with the one that divides right from left.
That's the median plane, also called the mid-sagittal plane. It's a vertical plane that passes right down the midline, dividing the body into equal right and left halves. Mirror images, essentially.
Equal halves. And any plane parallel to that?
Any vertical plane parallel to the median plane is called a sagittal plane. So the median plane is just one specific midline sagittal plane. You can have infinite sagittal planes off to the sides.
Okay, so median is the middle sagittal. Got it. What about dividing front from back?
Those are the frontal planes, also known perhaps more commonly as coronal planes. These also run vertically, but they're perpendicular to the sagittal planes. They divide the body into anterior front and posterior back parts. Think of looking at someone from the side. That view is often aligned with a frontal plane.
Frontal or coronal?
Okay.
And the last one, the one everyone recognizes from CT and MRI scans, the horizontal slice.
That's the transverse plane, often called the axial plane in imaging. This plane runs horizontally, dividing the body into superior, upper, and inferior lower parts. And critically, these cuts, these transverse planes, are always oriented at a right angle 90 degrees to the long axis of the body, or the specific body part being viewed.
Right angle to the long axis. That's key.
It is. That's what gives us those characteristic cross-sections of organs or limbs.
And the actual cut surface we see, the image itself, is called a section, right? And it's named based on the plane.
Exactly. A longitudinal section is any cut that runs lengthwise, parallel to the long axis of the body or part. Now, while median, sagittal, and frontal planes are the standard types of longitudinal sections, the text points out that technically you could make a longitudinal cut at any angle within a 180-degree range around that long axis.
Okay. And transverse sections?
Transverse sections or cross-sections are always cut at right angles to the long axis of the body or structure.
Okay, now here's where that long axis detail becomes really important. If I cut a transverse section of the main body trunk, that section lies in a horizontal plane, right?
Correct.
But what happens if I'm looking at, say, the foot? If I take a transverse section of the foot?
That's a fantastic question because it really clarifies the concept. When a person is standing in the anatomical position, the long axis of their foot runs horizontally parallel to the ground.
Right.
Therefore, a transverse section of the foot, a cut made at a right angle to its long axis, actually lies in the frontal coronal plane relative to the whole body.
Okay, that clicks. You always have to reference the long axis of the specific structure you're sectioning.
Precisely. And just to round it out, any cut or section that doesn't align with one of the standard planes, median, sagittal, frontal, or transverse, is, by definition, an oblique section. You see these quite often in clinical radiographic images, where the beam might pass through the body at an angle.
Oblique. Got it. Okay, planes and sections covered. Let's move on to the actual language of location. Terms of relationship and comparison. These always come in pairs, right? And they're absolute contrasts based on that anatomical position.
Correct. There are relative terms always used in comparison and always assuming the anatomical position.
Yeah.
Let's start vertically. Superior versus inferior.
Up and down.
Basically, yeah. Superior means nearer the vertex, which is the very top point of the cranium, the skull. The directional term often used is cranial, meaning towards the cranium. Inferior means nearer the sole of the foot. The directional term here is caudal, meaning towards the coccyx, the tailbone region. So a simple example. The heart is superior, or cranial, to the stomach. The stomach is inferior, or caudal, to the heart.
Makes sense. Front and back.
That's anterior versus posterior. Anterior denotes the front surface of the body. You'll also see the term ventral used, especially in embryology or comparative anatomy, but anterior is common clinically for the body surface.
Okay, anterior is front.
Posterior denotes the back surface. The term dorsal is often used interchangeably, similar to ventral. So the sternum, breastbone, is anterior to the heart. The vertebral column, spine, is posterior to the heart.
And there's a special term for the head.
Yes, particularly when talking about parts of the brain, we often use the term rostral. It means near the anterior part of the head towards the nose, essentially. So you might describe the frontal lobe of the brain as being rostral to the parietal lobe.
Rostral, towards the nose. Got it. Okay, now how about moving relative to that midline, the median plane?
That's where medial and lateral come in. Medial indicates a structure is nearer to the median plane, closer to the midline. Think about your hand. The fifth digit, the little finger, is medial compared to all the other fingers.
Right, it's closest to the body's midline if the palm is forward.
Exactly. Lateral means farther away from the median plane. The first digit, the thumb, is the most lateral digit in the anatomical position. Understanding medial and lateral is absolutely essential for describing, say, the path of a nerve or blood vessel, or the location of a lesion.
Very true. Now, specifically for the limbs, we have terms related to where they attach to the trunk, right? Proximal and distal.
Yes, these are crucial for describing locations along a limb, or even along a vessel or nerve within that limb. Proximal means near to the origin or attachment point of the limb, or near to the center trunk of the body. So the shoulder joint is at the proximal end of the upper limb. The elbow is proximal to the wrist.
Okay, closer to the body.
Distal means farther away from that attachment point or the root of the limb. The fingers are distal to the elbow, the toes are distal to the knee. And like I said, these terms also apply when describing parts of a structure within the limb. A blockage in an artery closer to the heart would be proximal to a blockage further down.
Proximal and distal, very important pair. What about describing depth or position relative to a cavity, or which side something is on?
Good points. For depth relative to the surface, we use superficial and deep. The skin is superficial to the muscles. The bones are deep to the muscles. Simple enough.
Okay.
For position relative to a cavity or hollow structure, we use external and internal. For example, the external oblique muscle of the abdomen lies superficial or external to the internal oblique muscle.
Right.
And finally, terms of laterality referring to the side or sides. Bilateral means occurring on both sides, like the lungs or kidneys. Unilateral means occurring on only one side, like the spleen or the appendix.
Ipsilateral and contralateral.
Right. Ipsilateral means on the same side of the body. For example, the right arm and the right leg are ipsilateral. Contralateral means on the opposite side of the body. The right arm and the left leg are contralateral. These are really important in neurology when discussing pathways that cross the midline.
Definitely. Okay, that covers all the static position terms. Now for the dynamics, Section 2 also covers terms of movement. This describes the actual mechanics, almost always happening at joints. Figure 1.5 in the text is great for visualizing these.
Yes, movement terms are essential for describing function and clinical assessment. Most movements are described in opposing pairs, and many occur in specific anatomical planes around specific axes. Let's start with the most common pair, flexion and extension.
Bending and straightening.
Pretty much. Generally, flexion is bending or decreasing the angle between bones or parts of the body. Think flexing your elbow. Extension is straightening or increasing that angle, moving back towards or beyond the anatomical position. For most joints above the knee, flexion involves movement in an anterior direction, and extension involves posterior movement.
Above the knee. Which brings us, inevitably, to the classic anatomy exception, the knee itself.
The knee, yes. Because the lower limb rotates medially during embryonic development, the front of the knee effectively faces posteriorly in terms of its primary action. So flexion of the knee involves posterior movement, bending the lower leg back towards the buttock.
Right.
Extension of the knee involves anterior movement straightening the leg. Recognizing the knee as the major exception to the general flexion-extension rule is absolutely crucial for clinically evaluating range of motion.
Definitely trips people up initially. And there's specialized flexion extension at the ankle too, right? Dorsiflexion and plantar flexion.
Exactly. We don't typically just say flexion extension for the main ankle joint.
Yeah.
Instead, dorsiflexion refers to bending the foot upward at the ankle, lifting the foot and toes towards the shin. Think about the movement you make when you're walking uphill or trying to lift your toes off the ground. The opposite is plantar flexion. This is bending the foot downward at the ankle, pointing the toes towards the ground, like when you stand on your tiptoes or press a gas pedal.
Dorsi up, plantar down. Got it. What about moving limbs away from or towards the midline?
That pair is abduction and adduction. Abduction means moving a limb away from the median plane of the body. It's abducting, taking away, lifting your arm out to the side.
Okay.
Adduction means moving the limb toward the median plane, adding it back to the body, bringing your arm back down to your side.
And does this apply to fingers and toes too?
Yes, but with a slight clarification. For the digits, fingers and toes, abduction means spreading them apart, away from the central axis of the hand or foot, which is the middle finger or second toe, respectively. Adduction means bringing them back together towards that central axis.
Ah, relative to the hand-foot axis, not the body midline. Good distinction. What about turning or twisting motions?
That's rotation. It describes turning or revolving a part of the body around its longitudinal axis. This can be medial rotation, also called internal rotation, where the anterior surface turns towards the median plane. Or it can be lateral rotation, also called external rotation, where the anterior surface turns away from the median plane. Think turning your whole leg inward or outward from the hip.
Okay. And that complex circular movement, like winding up to throw a ball.
That's circumduction. It's not a simple rotation. It's a sequential combination of flexion, abduction, extension, and adduction, or the reverse order. The proximal end of the limb stays relatively stable while the distal end describes the circle. You see it at the shoulder and hip joints primarily.
Circumduction. Got it. And the very unique twisting movement of the forearm.
Ah, yes. Pronation and supination. These are crucial. Pronation involves rotating the radius bone medially around the ulna. The result is that the palm faces posteriorly, or downward if the elbow is flexed. Think pouring out a bowl of soup.
Pouring out soup. Okay.
Supination is the opposite movement. The radius rotates laterally, returning the forearm to the anatomical position, so the palm faces anteriorly, or upward if the elbow is flexed. Think holding a bowl of sup soup.
Supination. Okay, I'll remember that. These are really fundamental for everyday tasks, like using tools or eating.
Absolutely. Loss of pronation or supination, maybe after a fracture, can be surprisingly debilitating.
Okay, nearly there with movements. What about specific foot movements and just general up-down shifts?
For the foot, besides dorsoplantar flexion, we have movements primarily at the subtalar and transverse tarsal joints. Inversion involves turning the sole of the foot toward the median plane, lifting the inner edge of the foot.
Okay.
Eversion involves turning the sole of the foot away from the median plane, lifting the outer edge of the foot. Think about twisting your ankle. Usually it's an inversion injury.
Right. And the up-down movement?
We use elevation and depression. Elevation raises or moves apart superiorly, like shrugging your shoulders, elevating the scapulae, or opening your eyelids wide, elevating the upper eyelid. Depression lowers or moves apart inferiorly, like letting your shoulders droop when standing at ease, depressing the scapulae, or closing your eye, depressing the upper eyelid.
And finally, the jaw and shoulder blade movements.
For the jaw and mandible, we use protrusion, which is moving it anteriorly, sticking your chin out. Retrusion is moving it posteriorly, pulling your chin back. For the shoulder blade scapula, similar movements on the posterior thoracic wall are called protraction, moving it anteriorly and laterally, like reaching forward, and retraction, moving it posteriorly and medially, like pulling your shoulders back.
Wow, okay, that's a comprehensive vocabulary for movement. But the text wisely closes this terminology section with a major dose of clinical reality, anatomical variations. We spent all this time learning the average human, but nobody is perfectly average, are they?
Not at all. And this is perhaps one of the most crucial takeaways for any budding clinician. What is normal? The text is very clear. Anatomical variation exists on a wide spectrum. It ranges from minor, functionally insignificant differences, maybe someone has an extra little muscle belly somewhere,
Right.
all the way to major variations that are incompatible with life, which we generally term birth defects or congenital anomalies.
And the actual incidence of variation is surprisingly high, isn't it?
It really is. The text notes that approximately 3% of newborns exhibit one or more significant birth defects. That could be something relatively minor functionally, like polydactyly, having extra fingers or toes, or something major structurally, like dextrocardia, where the heart is situated on the right side of the chest instead of the left.
3% is significant.
It is. And even beyond those major anomalies, everyday variations are incredibly common. Veins, for instance, demonstrate the greatest degree of variation in their branching patterns and connections. The venous drainage pattern in your arm is almost certainly quite different from the person sitting next to you.
Fascinating. What varies the least?
Nerves, thankfully, tend to show the least variation in their major pathways, which is helpful clinically, but variations still occur.
And the clinical importance of being aware of these variations becomes really critical when it involves vital structures, especially during surgery.
Oh, absolutely critical. Variations in the origin, the course, or even the number of important arteries, like the cystic artery supplying the gallbladder, which is notorious for variations, must be anticipated by surgeons. Accidentally cutting an unexpected accessory artery can lead to serious bleeding and complications.
Yeah, you don't want surprises like that.
Exactly. And that's why the experience of actually discovering these variations firsthand during dissection is so valuable for students. It develops a visceral awareness of their potential occurrence and frequency. It makes you less likely to be caught off guard when you encounter variation in a patient in the operating room or on an imaging scan. You start to expect the unexpected.
Expect the unexpected. Good mantra for anatomy. Okay. Excellent. With our fundamental language and the concept of variation established, let's move to Section 3. The integumentary system and fascia. We're essentially wrapping the body now, literally.
Right. Let's unpack the skin, the integumentary system. It's easy to overlook, but it is the body's largest organ, and it's an incredibly complex and functional containment unit. Figure 1.6 in the text gives a really nice cross-sectional view.
We think of skin as just protection, but its functions are much broader, aren't they?
Much broader. Yes, protection is key protection from environmental hazards like UV radiation, chemical injury, mechanical trauma, and preventing dehydration or fluid loss. But it also provides containment for the underlying tissues and fluids.
Containment, okay.
And then there's thermal regulation controlling body temperature through sweating and adjusting blood flow near the surface. Sensation is huge touch, pressure, pain, temperature receptors are all packed in the skin. And finally, a really important one, the synthesis and storage of vitamin D.
Ah, vitamin D, triggered by sunlight.
Exactly. Which is essential for calcium absorption from the gut. So the skin plays a vital role in maintaining skeletal health, too.
Structurally, we talk about two main layers, right? The outer non-vascular layer and the deeper vascular one.
Correct. The superficial layer is the epidermis. It's a stratified squamous epithelium, and it's keratinized, meaning the outer cells are tough, dead, and filled with keratin protein. This makes it highly protective. And critically, the epidermis is avascular. It has no blood vessels of its own.
So how does it get nutrients?
It relies entirely on diffusion of oxygen and nutrients from the capillary beds in the layer directly beneath it, the dermis. That's why a very superficial scrape, one that only removes epidermis, often doesn't bleed.
Okay, makes sense. And the layer beneath that is the dermis.
The dermis. This is the deeper, much thicker vascularized layer. It's made of dense, irregular connective tissue packed with robust interlacing collagen and elastic fibers. This dense structure is what gives the skin its strength, its toughness, and its elasticity or tone.
Collagen and elastic fibers. And the way those fibers are arranged leads to something really important for surgery, right? Tension lines or Langer lines?
Yes, absolutely. Tension lines, shown nicely in Figure 1.7, represent the predominant underlying orientation of those collagen fiber bundles within the dermis. They tend to run generally longitudinally in the limbs, but more transversely or horizontally across the neck and trunk.
And why does a surgeon need to care about the direction of these invisible lines?
Because they have a massive impact on wound healing and scarring. It's all about minimizing tension across the wound.
Okay.
An incision made parallel to the tension lines, meaning running in the same direction as the majority of the underlying collagen fibers, tends to heal much better and faster. The intact fibers on either side naturally hold the cut edges close together. This results in minimal scarring.
And cutting across them.
If you cut across the tension lines, you sever those collagen bundles. The natural elasticity of the surrounding skin then pulls the wound edges apart, causing the incision to gape open. This leads to slower healing, a higher risk of infection, and often results in excessive, raised, sometimes unsightly scarring, what we call keloid scarring. So, whenever possible, surgeons plan their incisions to follow these lines.
Fascinating. Okay, still within the dermis, deeper down, we find other important structures, including those involved in thermal regulation.
Yes, the deep dermis is where you find things like hair follicles. Associated with each hair follicle is a tiny smooth muscle, the erector pili muscle.
Goosebumps muscle.
That's the one. When it contracts, usually in response to cold or fear, it pulls the hair erect, causing goosebumps. This contraction also compresses the sebaceous glands, which are usually attached to the hair follicle, helping to secrete their oily substance, sebum. You also find sweat glands originating in the dermis, or even deeper.
And the blood vessels for temperature control.
Right. Thermal regulation is largely managed by the network of small arteries, or arterioles, within the dermis.
So how does that work if the body gets too hot?
If core body temperature rises, the thermoregulatory center in the brain, the hypothalamus, signals these dermal arterioles to dilate, to open up widely. This massively increases blood flow into the superficial capillary beds near the skin surface. Warm blood is exposed to the cooler outside air, allowing heat to radiate away. The skin appears red or flushed.
And if you're cold?
If the body needs to conserve heat, the opposite happens. The arterioles are signaled to constrict to narrow significantly. This shunts blood away from the surface, reducing heat loss. This can make the skin appear pale, or if oxygen levels also drop, even bluish.
Okay, that makes sense. Now, beneath the dermis, there's that layer of padding most of us are familiar with.
Yes, that's the subcutaneous tissue. It's also known as the superficial fascia, or sometimes the hypodermis. Figure 1.8 shows it well. It lies between the dermis and the underlying deep fascia covering the muscles.
And it's mostly fat.
Primarily, yes. It's composed mainly of loose connective tissue and stored fat, adipose tissue. Its thickness varies enormously depending on the body region and the person's nutritional state. It serves as the body's main energy storage depot. It acts as an insulator against heat loss, and it provides protective padding or shock absorption over bony areas.
It's also where the superficial nerves and vessels run.
Exactly. It serves as the pathway for the larger superficial veins, lymphatic vessels, and cutaneous nerves before they branch out further to supply the dermis and epidermis.
And the distribution of this fat layer, it varies quite a bit between individuals.
Tremendously. Based on nutrition, obviously, but also significantly based on age and sex. In mature females, for example, fat tends to accumulate more in the breasts, hips, buttocks, and thighs. In males, it often concentrates more in the lower abdominal wall, the classic spare tire region.
Right.
Conversely, some areas have almost no subcutaneous tissue. Think about the shin bone or the back of your hand. That's why knocks to those areas can be particularly painful, as there's very little cushioning over the bone or tendons.
And what holds the skin down onto the deeper layers?
That's the role of the skin ligaments, technically called retinacula cutis. These are numerous small fibrous bands that extend from the deep surface of the dermis through the subcutaneous tissue and anchor into the underlying deep fascia. Their length and density determine how mobile the skin is in a particular area. They're short and abundant in the palms and soles, holding the skin firmly, but longer and sparser on the back of the hand, allowing more movement.
Retinacula cutis. Okay, let's shift now to section 4, clinical aspects of skin and fascia. We touched on thermal regulation signals, but what about other color changes that are diagnostic clues?
Skin color can provide really rapid, important diagnostic clues, as described in the clinical box on page 107. We mentioned constriction causing pallor. If oxygen levels in the blood become significantly low, we see cyanosis.
The bluish tint.
Right. It's a bluish or purplish discoloration, often most apparent where the skin is thin, like the lips, nail beds, or earlobes. It's caused by an increased amount of deoxygenated hemoglobin in the capillaries. That deoxyhemoglobin has a darker purplish blue color that shows through the skin. It signals a serious problem with oxygenation, either respiratory or circulatory failure.
Okay, cyanosis is blue due to low oxygen. What about redness or yellowing?
Abnormal redness is called erythema. This results from engorgement of the superficial capillary beds with oxygenated blood.
Right.
It's typically due to localized inflammation, like from an injury or infection, exposure to heat, like sunburn, allergic reactions, or even systemic fever.
And yellow.
Yellowing of the skin, and often starting in the whites of the eyes, the sclerae, is called jaundice. This is caused by the buildup of a yellow pigment called bilirubin in the blood. Bilirubin is a breakdown product of hemoglobin, normally processed by the liver and excreted in bile. So jaundice usually indicates some kind of liver disorder or perhaps a blockage of the bile ducts.
Now, I remember the text making a really important point about assessing these color changes in individuals with darker skin tones.
Yes, that is a critical clinical consideration. The natural melanin pigment in darker skin can easily mask subtle color changes, like mild cyanosis or early jaundice. Erythema from inflammation might also be harder to discern visually.
So where should clinicians look?
They must examine areas where the natural pigment is normally much lower, regardless of overall skin tone. Good places include the mucous membranes, like the underside of the tongue or the inside of the lips, buccal mucosa, the conjunctiva lining the inside of the eyelids, and sometimes the palms of the hands and soles of the feet. Assessing these areas is crucial for accurate diagnosis in all patients.
Essential point. Okay, let's talk trauma. The text covers both the gradual damage, like stretch marks, and the acute severe trauma of burns.
Right. Stretch marks, or striae, are interesting. They're actually scars within the dermis. They're caused by rapid increases in size, like during pregnancy, rapid weight gain, obesity, or even rapid muscle growth in bodybuilders. This rapid stretching damages the underlying dermal collagen and elastic fibers. They typically start off reddish or purplish and eventually fade to silvery white lines, but the damaged structure remains.
Okay. Now, burns. Burn classification is probably one of the most immediate and vital clinical applications from this whole chapter. We classify them based on depth into 4 degrees.
Yes, and the classification is absolutely key because it dictates prognosis, treatment, and potential complications. Let's go through them. First is a superficial burn, previously called first degree.
Like a typical sunburn.
Exactly. This involves damage limited to the epidermis only. It causes pain, erythema, redness, and maybe mild swelling, but the barrier function isn't totally breached, and it typically heals quickly, within a few days, from the surviving basal cells, usually without scarring.
Okay. What's next deeper?
Partial thickness burns, previously second degree. These damage the epidermis and extend into the superficial part of the dermis. These are characterized by blistering fluid collecting between the epidermis and dermis. And critically, these are usually the most painful type of burn.
Most painful? Why is that?
Because the nerve endings in the dermis are damaged and irritated but not completely destroyed, so they're firing pain signals intensely. Healing takes longer, typically weeks to months, and often leaves some scarring because dermal structures are involved. There's also a distinction sometimes made between superficial partial thickness and deep partial thickness, depending on how much dermis is involved.
Okay, partial thickness is blistered and very painful. What's third?
Full thickness burns, previously third degree. These destroy the entire thickness of the skin, both the epidermis and the entire dermis, and often extend into the subcutaneous tissue. The burned area itself is typically numb or anesthetic.
Numb? Why numb if it's so deep?
Because the sensory nerve endings in the dermis have been completely destroyed by the heat. The surrounding areas might be painful, partial thickness, but the central full thickness area is insensate. The surface might look waxy white, leathery, or charred brown-black. These burns cannot heal on their own from the base. They require surgical excision of the dead tissue, eschar, and skin grafting, usually using an autograft, which is skin taken from an unburned area of the patient's own body.
Full thickness needs grafting. And the worst category?
Fourth-degree burns. These are devastating injuries that extend through the entire skin, through the subcutaneous tissue, and into the underlying deep fascia, muscle, or even bone. These are often associated with prolonged exposure to high heat or electrical injuries. They are obviously life-threatening, often require extensive reconstruction or even amputation, and signify massive tissue destruction.
4 degrees of increasing severity. And for quickly assessing how much of the body surface is affected, especially in the field or ER, we use the rule of nines.
Yes. The rule of nines, shown in figure B1.3, is a rapid estimation tool used primarily for adults. It divides the total body surface area, TBSA, into regions that are approximately 9% or multiples of 9%.
Can you run through the basic percentages?
Sure, for an adult. The entire head and neck is considered 9% of TBSA. The entire front of the trunk, chest and abdomen, is 18%. The entire back of the trunk, upper and lower back, is 18%. Each entire upper limb, arm, forearm, hand, is 9%. Each entire lower limb, thigh, leg, foot, is 18%. And the perineum, the genital area, accounts for the final 1%.
So adding those up gives 100%.
Exactly. It allows emergency personnel to quickly estimate the percentage of TBSA affected by partial or full thickness burns. This estimation is crucial for determining the severity, guiding fluid resuscitation protocols, major burns cause massive fluid loss, and deciding if the patient needs transfer to a specialized burn center. Generally, burns covering 20% TBSA or more are considered major burns, requiring intensive care. The percentages are different for infants and children due to their different body proportions.
A very practical tool. Okay, we've covered the skin and subcutaneous tissue. Let's move to the layer beneath that, the deep fascia. This sounds like the body's internal, organized cling film.
That's not a bad analogy. Deep fascia, illustrated in figure 1.9, is a layer of dense, organized connective tissue. It's devoid of fat, unlike the superficial fascia. It completely envelops the body, lying just deep to the subcutaneous tissue and superficial fascia. It's tough, fibrous, and generally quite unyielding or inelastic.
And its function is mainly containment and organization.
Primarily, yes. It forms a strong membrane that covers and contains the underlying muscles and other structures, but it also has important extensions that create further organization.
Extensions, like partitions.
Exactly. 3 key types of extensions arise from the deep fascia. First, intermuscular septa. These are thick sheets of deep fascia that extend inward from the main enveloping layer to attach directly to bones. They act like walls, dividing groups of muscles into fascial compartments.
Fascial compartments. I've heard that term. Why are they important?
They're very important functionally and clinically. Muscles located within a single fascial compartment typically share similar functions. Flexing the forearm, are innervated by the same major nerve and often share a common blood supply. This organization is key to understanding regional function.
Okay, septa divide compartments. What are the other extensions?
Second, you have investing fascia. This is essentially the deep fascia continuing over individual muscles and also surrounding groups of muscles or neurovascular bundles, nerves and vessels traveling together, and sheathing them like a sleeve.
Investing like a vest. Got it.
Third, in certain areas, particularly around joints like the wrist and ankle, the deep fascia becomes significantly thickened to form retinacula. These act like strong bracelets or straps.
To hold things down.
Precisely. They hold tendons in place, preventing them from bowstringing away from the joint when the muscles contract and the joint moves. They ensure efficient transfer of force.
Okay, intramuscular septa, investing fascia, retinacula. Now, you said the deep fascia is quite unyielding. That seems counterintuitive for movement. But you mentioned earlier it's actually essential for something called the musculovenous pump.
Yes, this is a brilliant piece of physiological engineering, especially important in the limbs, particularly the legs, for getting blood back to the heart against gravity.
These does work.
When the skeletal muscles within a fascial compartment contract vigorously, like when you walk or run, they bulge. But because the surrounding deep fascia is strong and doesn't stretch easily, it limits how much the muscle can expand outward.
Okay.
Instead, the increased pressure from the contracting muscle is directed inward. This inward pressure effectively squeezes or compresses the deep veins that run through the compartment alongside the muscle.
Ah, squeezing the veins.
Exactly. Now, these deep veins have numerous one-way valves inside them that only allow blood to flow towards the heart, preventing backflow. So when the veins are squeezed by the contracting muscles against the rigid fascial wall, the blood is forced upward towards the heart. When the muscles relax, the pressure drops, and the veins refill with blood from below, ready for the next squeeze.
It's like milking the blood upward.
That's exactly the term often used, a milking action. Without that tough, unyielding deep fascia providing counterpressure, the muscle contraction would just cause the compartment to bulge out, and the pump mechanism would be far less effective, leading to blood pooling in the legs.
Fascinating. Okay, besides the main fascial layers, we also need to understand structures that reduce friction, like bursae, and these things called serous sacs. The text uses a fist in a balloon analogy for the sacs.
Yes, let's tackle bursae first. Bursa are essentially closed sacs or pockets of serous membrane. A serous membrane is a thin layer of cells that produces a lubricating fluid, similar to synovial fluid in joints.
And where do you find bursae?
You find them in locations where structures might rub against each other and potentially cause friction damage. Common spots are between skin and bone, like over the elbow or knee, between tendons and bone, between muscles, or between ligaments and bone. They contain a thin film of fluid that allows these adjacent structures to glide smoothly over one another during movement. Think of them as little lubricating cushions.
Okay, bursae reduce friction locally. Now, the serous sacs and the fist in a balloon analogy, figure 1.10, that's for larger structures.
Yes, this analogy helps understand how major organs, particularly those that need to move or change shape within body cavities, are arranged. Think of the heart within the chest, the lungs, or the abdominal viscera. These organs aren't just loosely sitting in the cavity. They're typically surrounded by a closed, fluid-filled sac made of serous membrane.
So the fist is the organ.
Right. Imagine pushing your fist, the organ like the heart, into the side of an underinflated balloon, the serous sac. Your fist doesn't actually enter the airspace of the balloon, but it becomes surrounded by two layers of the balloon wall pressed closely together.
Ah, I see. One layer touching the fist, one layer forming the outer wall.
Exactly. The layer of the serous membrane directly adhering to the surface of the organ, your fist, is called the visceral layer. For example, the visceral pericardium on the heart, visceral pleura on the lung. The outer layer, lining the wall of the body cavity, the outer part of the balloon, is called the parietal layer, AG parietal, pericardium, parietal pleura.
And the space between those two layers, the potential space.
Right. Between the visceral and parietal layers is a very thin potential space that contains only a tiny film of lubricating serous fluid secreted by the membrane cells. This setup is brilliant because it allows the organ, like the beating heart or the expanding lungs, significant mobility within its confined space, gliding almost frictionlessly against the cavity wall thanks to that lubricating fluid between the visceral and parietal layers. Examples include the pericardial sac around the heart, the pleural sacs around the lungs, and the peritoneal sacs surrounding many abdominal organs.
Visceral layer on the organ, parietal layer on the wall, potential space with fluid in between.
Got it. Finally, for this section, what's the big clinical takeaway regarding these fascial layers and planes?
The clinical importance, especially for surgeons, is huge. Fascial planes, the potential spaces containing loose connective tissue between adjacent fascial layers or compartments, act as natural cleavage planes. Surgeons often utilize these planes during operations because they can be separated relatively easily with minimal bleeding, providing access to deeper structures.
Okay, surgical access. What about pathology? Fascial boundaries also dictate how infections or even tumors might spread. Pus from an infection or fluid-like blood from an injury will often track along the path of least resistance, spreading within a fascial compartment or along a specific fascial plane. Conversely, the dense, deep fascia itself often acts as a strong barrier, temporarily containing an infection or preventing the immediate spread of a tumor into an adjacent compartment. Knowing the anatomy of these fascial compartments and planes is therefore critical for predicting the spread of disease and planning effective surgical drainage or excision. The clinical box on page 113 gives some good examples.
Excellent. Understanding the body's wrapping and internal packaging is key. We've wrapped the body, now let's move deep inside to section 5, the skeletal system.
The framework.
Right, the skeleton, our internal scaffolding, composed of two main living tissues, resilient cartilage and rigid bone. And as figure 1.11 shows, we divide the skeleton into two principal parts.
Axial and appendicular. Correct. The axial skeleton forms the central axis of the body. The bones of the head, cranium, neck, cervical vertebrae, hyoid bone, and trunk, ribs, sternum, vertebrae, sacrum. The appendicular skeleton consists of the bones of the limbs upper and lower, including the bones that form the pectoral, shoulder girdle, and the pelvic girdle, which attach the limbs to the axial skeleton.
Let's start with cartilage, the more flexible component. What makes it structurally distinct from bone?
Cartilage is a resilient, semi-rigid type of connective tissue. It provides flexible support in places like the joints, as articular cartilage covering bone ends, the respiratory tract, rings in the trachea, and the costal cartilages connecting ribs to the sternum. Its key structural distinction, which has major functional consequences, is that cartilage is avascular.
Avascular, no blood vessels, or lymphatics or nerves, usually.
Right. It contains no blood vessels or lymphatics within its matrix.
So how does it get nutrients and oxygen, and how does that affect healing?
The cartilage cells, the chondrocytes, embedded within the matrix, receive their oxygen and nutrients solely by long-range diffusion through the matrix, usually from blood vessels in the surrounding connective tissue, the perichondrium, or from synovial fluid in joints.
Diffusion is slow.
Very slow and relatively inefficient, especially in thick cartilage. This has a major consequence. Cartilage has a very limited capacity for repair when damaged. It heals very slowly, or often not at all, being replaced by fibrous scar tissue instead. Contrast this with bone, which is highly vascular and heals relatively well.
And we see more cartilage proportionally in infants.
Yes. A newborn skeleton has a much higher proportion of cartilage compared to an adult's. Many bones that are solid in adults exist primarily as cartilaginous models in infants, making their skeletons softer and more flexible. This cartilage is gradually replaced by bone during growth.
Okay, cartilage is avascular and heals poorly. Moving to bone, the rigid part. Let's quickly recap its major functions.
Bone has several vital functions. 1. Protection for vital structures. Think of the cranium protecting the brain, or the rib cage protecting the heart and the lungs. 2. Support for the body and its cavities. 3. It provides the mechanical basis for movement, acting as levers that muscles pull on to produce motion at joints. 4. Storage for salts, primarily calcium and phosphate. 5. And critically, it houses the bone marrow, responsible for hematopoiesis, the continuous supply of new blood cells, red cells, white cells, platelets.
And bones like cartilage have a specialized outer covering.
Yes. Bones are covered externally, except where there's articular cartilage, by a tough fibrous connective tissue membrane called the periosteum. Cartilage, where it's not at an articular surface, is covered by a fibular membrane called the perichondrium. These membranes are important because they contain blood vessels that nourish the outer parts of the bone or cartilage, and they also contain cells capable of forming new bone or cartilage, which is crucial for growth and fracture healing. They're also rich in sensory nerves, which is why damage to the periosteum is very painful.
Okay. Structurally, within a single bone, we typically see two different types of bone tissue.
Correct. We differentiate between compact bone and spongy bone. Figure 1.12 shows this well. Compact bone forms the dense, solid outer layer or shell of all bones. It provides strength, rigidity, and resistance to bending forces. It looks solid to the naked eye, although it's riddled with microscopic canals for blood vessels, Virgin systems.
And spongy bone.
Spongy bone, also called cancellous or trabecular bone, is found internally, particularly within the ends of long bones, the epiphyses, and filling the interior of vertebral bodies, flat bones, and irregular bones. It consists of a meshwork or lattice of thin, interconnecting bony struts or plates called trabeculae.
Trabeculae.
These trabeculae are not randomly arranged. They are oriented along lines of stress, providing maximum strength with minimum weight. The spaces between the trabeculae are filled with bone marrow, red marrow, producing blood cells, or yellow marrow, mostly fat.
Compact outside, spongy inside with marrow. Now, the text classifies bones into 5 categories based purely on their overall shape. This seems like a helpful way to organize them.
It is. It's a simple morphological classification. 1. Long bones. These are tubular in shape, clearly longer than they are wide. Examples include the humerus in the arm, the femur in the thigh, and even the smaller phalanges in the fingers and toes. They function primarily as levers for movement. 2. Short bones. These are roughly cuboidal or cube-shaped, found only in the wrist, carpal bones, and the ankle foot, tarsal bones. They provide stability and help absorb shock. 3. Flat bones. These are generally thin, flattened, and often slightly curved. They primarily serve protective functions, like the bones forming the vault of the cranium protecting the brain, or the sternum and ribs protecting thoracic organs, or provide broad surfaces for muscle attachment, like the scapula. 4. Irregular bones. These have complex, peculiar shapes that don't fit neatly into the other categories. Examples include the vertebrae, which have intricate shapes for support, movement, and protecting the spinal cord, or the oddly shaped bones of the face and the hip bones. 5. Sesamoid bones. These are spiral types of bones that develop within certain tendons. They are typically small and roundish, found where tendons cross the ends of long bones in the limbs. They protect the tendon from excessive wear and can change the angle of the tendon, improving the muscle's leverage. The largest and most constant sesamoid bone is the patella, kneecap, located in the quadriceps tendon.
Long, short, flat, irregular, sesamoid. Got it. And the surfaces of all these bones aren't smooth, are they? They're covered in bumps, grooves, holes, bone markings, and formations. Figure 1.13 shows some examples.
Right. The surface of a bone is like a topographical map reflecting its history and function. These markings are where tendons, ligaments, and fascia attach, where arteries lie adjacent or nerves pass through, or where bones articulate with each other. They're not random. They develop in response to mechanical stresses.
Can you give a few examples of types of markings? The text lists quite a few on page 117.
Sure. Markings related to joints often have specific names, like a condyle, a rounded articular area like on the femur at the knee, a facet, a smooth flat area where a bone articulates like on vertebrae, or a head, a large rounded articular end like on the humerus or femur. Markings for attachments include things like a crest, a ridge of bone, an epicondyle, an eminence superior to a condyle, a line or linear elevation, a process, a spine-like projection, a trochanter, a large blunt elevation only on the femur, a tubercle, a small raised eminence, or a tuberosity, a large rounded elevation. Depressions or openings include a fossa, a hollow or depressed area, a groove or sulcus, a furrow, a notch, an indentation, or foramen, a hole or passage through bone. Recognizing these is key to orienting bones and understanding attachments.
A whole vocabulary just for bone bumps. Okay, let's talk about how bone actually develops. Ossification. It's a long process you mentioned, taking years.
It is. The humerus, for instance, starts ossifying very early in fetal life, around the 8th week of gestation. But the whole process of growth and complete fusion isn't finished until maybe age 20. All bone develops initially from embryonic connective tissue called mesenchyme. There are 2 fundamental ways this happens.
2 processes.
Yes. The first is intramembranous ossification. Here, bone forms directly from or within a mesenchymal membrane template. Mesenchymal cells differentiate directly into bone-forming cells, osteoblasts, that start laying down bone matrix. This membranous bone formation is how most of the flat bones of the skull, like the frontal and parietal bones, and the clavicle develop.
Directly from mesenchyme.
Okay.
And the second process. This one involves cartilage first.
Correct. That's endochondral ossification. This is how most bones in the body form, especially long bones and short bones. In this process, a cartilage model of the future bone first develops from the mesenchyme. Then, this cartilage model is gradually replaced by bone tissue. It's cartilaginous bone formation. The cartilage doesn't transform into bone, rather it serves as a template that gets broken down and replaced.
Endochondral uses a cartilage model. Let's focus on how a typical long bone grows in length using this endochondral process. Figure 1.12 is key here. We need to define the main parts involved in growth.
Okay, for a typical long bone developing via endochondral ossification, the first site where bone tissue starts to replace the cartilage model is usually in the middle of the shaft. This is called the primary ossification center, and it forms the diaphysis, the shaft or body of the long bone.
Primary center forms the diaphysis.
Shaft. Then, usually later, often after birth, secondary ossification centers appear in the ends of the cartilage model. These form the epiphysis, Singular deficits, the expanded ends of the long bone that articulate with other bones at joints.
Secondary centers form the epiphyses, ends.
Now, during the entire growth period, from infancy through childhood and adolescence, a plate of hyaline cartilage persists between the diaphysis and each epiphysis. This is the crucial epiphyseal plate, often called the growth plate.
The growth plate, this is literally where the bone gets longer.
Exactly. The cartilage cells within the epiphyseal plate are constantly proliferating, dividing on the epiphyseal side, increasing the plate's thickness. Simultaneously, on the diaphyseal side of the plate, the older cartilage cells hypertrophy, die, and the cartilage matrix calcifies and is then broken down by osteoclasts and replaced by bone, laid down by osteoblasts invading from the diaphysis.
So cartilage grows on one side, gets replaced by bone on the other.
Precisely. This process effectively pushes the epiphysis further away from the diaphysis, causing the bone to lengthen. The flared part of the diaphysis nearest the growth plate is called the metaphysis. This process continues until somatic growth ceases, typically in the late teens or early 20s.
And what happens when growth stops?
When growth is complete, the cartilage cells in the epiphyseal plate stop proliferating. The remaining cartilage is completely replaced by bone. The diaphysis then fuses with the epiphysis in a process called epiphyseal fusion or synostosis. This fusion obliterates the growth plate, leaving behind a dense bony line, the epiphyseal line, which is visible on radiographs in adults and indicates that longitudinal growth has ended.
Epiphyseal line means growth is done.
Yeah.
That's a really elegant mechanism. We also need to constantly reinforce the idea that bone isn't just dead scaffold. It's a living, dynamic organ.
Absolutely vital concept. Bone is living tissue. It's highly vascularized, meaning it has a rich blood supply. Figure 1.15 shows typical arterial supply. This is why bones bleed profusely when fractured.
And they hurt?
They hurt immensely when injured because they're also richly innervated with sensory nerves, especially in the periosteum. Bones undergo constant internal remodeling throughout life. Old bone is resorbed by osteoclasts, and new bone is laid down by osteoblasts, adapting to mechanical stresses.
So they change based on use.
Definitely. Bones demonstrate Wolff's law. They adapt to the loads placed upon them. They will atrophy, decrease in bone mass and density, if they are unused or unloaded for extended periods. Think of bone loss in a paralyzed limb, or during prolonged bed rest or spaceflight. Conversely, bones will hypertrophy, increase in density and sometimes size, when subjected to chronic increased mechanical stress, like the bones of athletes adapting to support increased weight or impact forces. They are constantly adapting.
Living, bleeding, hurting, remodeling, adapting. Got it. Okay, let's transition now into the final part, section 6, clinical aspects of bones and introduction to joints, starting with some specific bone-related clinical concepts from the box on pages 121, 124.
Right. The text highlights several important clinical points related to bone. One interesting one is heterotopic bones.
Heterotopic, meaning other place, bone forming where it shouldn't?
Exactly. Sometimes bone tissue develops in soft tissues where bone doesn't normally exist. The classic example given is writer's bones, occasional development of bony patches within the adductor muscles of the thigh in experienced horse riders.
Why does that happen?
The thinking is that chronic muscle strain and repeated microtrauma cause small hemorrhages, bleeding, within the muscle tissue. These areas can then undergo calcification and eventually ossification, true bone formation in an abnormal location.
Fascinating. The text also mentions accessory bones and assessing bone age.
Yes, accessory bones, or supernumerary bones, are relatively common. These develop when additional ossification centers appear and form extra bones, often near epiphyses. They need to be distinguished from fractures on imaging. Assessment of bone age is important in pediatrics. Radiologists can determine a child's skeletal maturity by looking at radiographs, usually the hand and wrist, and comparing the appearance and fusion status of the ossification centers and epiphyseal plates to standardized atlases for different ages. This can help diagnose growth disorders.
And osteoporosis.
Osteoporosis is a significant clinical issue, especially in older adults, particularly postmenopausal women. It's characterized by a reduction in the quantity of bone mass or atrophy of skeletal tissue. The bones become brittle and susceptible to fracture, even from minor trauma. Figure B1.5 shows the difference in trabecular structure.
Okay. We also need to revisit the impact of trauma or illness on the growth plates, the epiphyses.
Yes, two key points here. First, related to illness. Severe illness or periods of starvation during childhood can temporarily slow down the rate of cartilage proliferation at the epiphyseal plates. However, the process of cartilage destruction and replacement by bone on the diaphyseal side might continue. This can result in a denser temporary band of calcification at the metaphysis, visible on radiographs later as lines of arrested growth, marking the period of illness.
Lines of arrested growth, wow. And fractures involving the growth plate.
Fractures that cross or damage the epiphyseal plate in a growing child are particularly concerning. Figure B1.4. Because the plate is responsible for longitudinal growth, injuring it can disrupt that process. Depending on the severity and type of injury, there's a specific classification system, Salter-Harris, it can potentially lead to premature closure of the plate in the injured area, resulting in the bone ending up shorter than its counterpart on the other side, or growing at an angle.
That highlights a really crucial diagnostic challenge in kids, doesn't it? Distinguishing a growth plate injury from a regular fracture.
Yes, epiphyseal displacement versus fracture. This is critical. In children and adolescents, the epiphyseal plate, being cartilage, is structurally weaker than the surrounding ligaments and bone tissue. Therefore, an injury force that might cause a ligament sprain or a fracture in an adult often causes the epiphysis to separate from the diaphysis through the growth plate in a child.
So how do you tell the difference on an X-ray?
A true fracture through bone typically leaves a sharp, jagged, irregular break line. A displaced epiphysis, however, involves separation along the relatively smooth, often curved plane of the cartilaginous growth plate. Recognizing this distinction is vital, as mismanagement of a growth plate injury can have those severe long-term consequences on limb length and alignment.
Very important point for anyone looking at pediatric X-rays. Finally, before joints, the text mentions a serious potential complication of bone injury, a vascular necrosis, or AVN.
Right. A vascular necrosis literally means death, necrosis of bone tissue due to a lack of blood supply. Bone cells, like all living cells, need a constant supply of oxygen and nutrients from the blood. If the arterial supply to a portion of bone is interrupted, often due to a fracture that disrupts the feeding vessels, especially common in fractures of the femoral neck and the hip or the scaphoid bone in the wrist, that segment of bone can die.
And what happens to the dead bone?
The dead bone eventually collapses or gets resorbed, leading to pain, joint dysfunction, and secondary arthritis. The text also mentions osteochondrosis, which are a group of clinical disorders seen in children where AVN affects specific epiphyses, often for reasons that aren't entirely clear, idiopathic. It really underscores how critical that vascular supply, figure 1.15, is for maintaining healthy living bone.
Okay, that covers the key clinical bone points. Let's finally transition to joints, or articulations. These are simply the unions or junctions between two or more bones or rigid parts of the skeleton.
Right. And how they're joined determines how much or how little they can move. We classify joints based on the type of material that unites the articulating bones. This gives us three main structural classes.
3 classes, what are they?
1. Synovial joints. These are the most common type and allow the greatest degree of movement. Their key feature is the presence of a joint cavity between the bones. 2. Fibrous joints. In these joints, the bones are united by dense fibrous connective tissue. There's no joint cavity, and movement is very limited or none at all. 3. Cartilaginous joints. Here, the bones are united either by hyaline cartilage or fibrocartilage. Again, no joint cavity, and movement is typically slight.
Let's unpack synovial joints first, as they're the most complex and allow most familiar movements. What are their defining features? Figure 1.1CA is helpful here.
Synovial joints have several characteristic features. First, the bone ends involved in the joint are covered with smooth, slippery articular cartilage, usually a hyaline cartilage. This reduces friction and absorbs shock. Second, the bones are united and the joint is enclosed by an articular capsule. This capsule has 2 layers, an outer tough fibrous layer, or fibrous capsule, that provides stability, and an inner synovial membrane.
Synovial membrane, that sounds important.
It is. The synovial membrane lines the entire inner surface of the fibrous capsule, except where there's articular cartilage. Its primary job is to produce synovial fluid.
The lubricant.
Exactly. Synovial fluid is a viscous, clear, or pale yellow fluid that fills the joint cavity, the potential space between the articular cartilages. It lubricates the joint surfaces, reducing friction even further, and it also nourishes the avascular articular cartilage. Many synovial joints also have accessory ligaments, either outside or inside the capsule, and sometimes internal structures like articular discs or menisci, fibrocartilage pads that further enhance stability or congruence.
Okay, synovial joints have cartilage, capsule, cavity, and fluid, allowing free movement. What about the other two types, the non-synovial ones, fibrous joints next?
Right. Fibrous joints are united by fibrous tissue. Movement depends on the length of the fibers uniting the bones. There are three specific types, figure 1.1 b.
These are found only in the skull. The bones are interlocked by very short interconnecting fibers, essentially allowing no movement in adulthood. Think of the jagged lines between the flat bones of your cranium.
In this type, the bones are united by a sheet or ligament of fibrous tissue, called an interosseous membrane or ligament. Example, the membrane connecting the shafts of the radius and ulna in the forearm, or the tibia and fibula in the leg. This allows for a small amount of movement or give.
This is a specialized type, also called a dentoalveolar joint. It's basically a peg and socket joint where a tooth root is anchored into its bony socket in the jaw by the fibrous periodontal ligament. Allows only very slight physiological movement.
Sutures, syndesmosis, kyphosis, or again the third main class, cartilaginous joints.
Cartilaginous joints are united by cartilage, either hyaline or fibrocartilage. Figure 1.16c. Again, no joint cavity. Two types here. One, synchondroses, primary cartilaginous joints. The bones are united by hyaline cartilage. These are typically temporary joints related to growth, like the epiphyseal plate connecting the diaphysis and epiphysis of a growing long bone. They permit growth but allow essentially no movement. Once growth stops, they fuse, synostosis. Another example is the joint between the first rib and the sternum, which persists. 2. Symphyses, secondary cartilaginous joints. Here, the articulating surfaces of the bones are covered with hyaline cartilage, but they are then united by a strong, slightly flexible pad of fibrocartilage. These joints are strong and allow limited movement, primarily for shock absorption. Classic examples are the intervertebral discs between adjacent vertebral bodies and the pubic symphysis joining the two hip bones anteriorly.
Synchondrosis, hyaline, often temporary growth. Symphysis, fibrocartilage, slight movement, shock absorption. Great summary. Now let's go back to the highly mobile synovial joints. The text further classifies these into 6 subtypes based on the shape of the articulating surfaces and the type of movement allowed. Figure 1.17 is the key visual here.
Yes, this functional classification helps understand the specific mechanics of different synovial joints. 1. Plane joints. Articular surfaces are essentially flat or slightly curved. They permit only gliding or sliding movements in one plane. They are uniaxial. Example, the acromioclavicular joint between clavicle and scapula, or intercarpal joints in the wrist. 2. Hinge joints. Permit movement primarily in one plane only, flexion and extension. Also uniaxial, like the hinge of a door. Example, the elbow joint, specifically the humeral ulnar articulation, or the interphalangeal joints of the fingers and toes. 3. Saddle joints. Articular surfaces are reciprocally saddle-shaped concave in one direction and convex in the other, fitting together like a rider on a saddle. They are biaxial, allowing movement in two planes, flexion, extension, and abduction-adduction, plus circumduction. Example, the carpometacarpal joint of the thumb, which gives the thumb its unique opposability. 4. Condyloid joints, also called ellipsoidal joints, permit movement in two planes, flexion, extension, and abduction-adduction. They are also biaxial. Circumduction is possible, but usually more restricted than in a saddle or ball and socket joint. The key difference from a saddle joint is that rotation is typically prevented. Example, the metacarpophalangeal joints, the main knuckles of the hand, or the wrist joint, radiocarpal. 5. Ball and socket joints. A rounded, ball-like head of one bone fits into a cup-like socket of another. These are multiaxial, allowing movement in all three planes. Flexion, extension, abduction, adduction, and mediolateral rotation. They offer the greatest range of motion of any joint type. Classic examples, the hip joint and the glenohumeral shoulder joint. 6. Pivot joints. A rounded process of bone rotates within a sleeve or ring composed of bone and or ligament. They are uniaxial, permitting only rotation around a central axis. Example, the atlantoaxial joint in the neck, allowing you to shake your head no, or the proximal radial ulnar joint in the elbow region, essential for pronation and supination of the forearm.
Plane, hinge, saddle, condyloid, ball and socket, pivot. 6 types covering the spectrum of synovial movement. It's also clear that these joints, being active sites, must be heavily influenced by their blood supply and nerve supply.
Absolutely. Joints are living structures that require nourishment and control. They receive a rich blood supply via articular arteries. These typically arise from the vessels around the joint and often form networks, called anastomoses, articular anastomoses, communicating with each other. This ensures the blood supply to the joint remains relatively consistent, even if one vessel is compressed during certain movements. Articular veins accompany the arteries.
And the nerve supply, what's its main job?
Joints are also richly supplied by articular nerves, which are branches of the nerve supplying the overlying skin and the muscles that move the joint. These nerves transmit sensory information, including pain signals if the joint is injured or inflamed. But perhaps even more importantly, they transmit the sensation of proprioception.
Proprioception, that sense of where your body parts are in space.
Exactly. It's our largely subconscious awareness of joint movement, kinesthesia, and position, even with our eyes closed. This constant feedback from articular nerves and muscle spindles, tendon organs, allows the nervous system to coordinate muscle activity smoothly and maintain balance and posture.
This overlap in nerve supply joint, muscles moving it, skin over it, brings us to that famous clinical rule of thumb, Hilton's Law.
Yes, Hilton's Law is a very useful clinical guideline. It basically states that the nerves supplying a joint also tend to supply the muscles that move that joint and the skin covering the distal attachments of those muscles.
Why is that useful clinically?
It helps explain patterns of referred pain. For example, pain originating from inflammation within the hip joint might be perceived by the patient not just in the hip region but also in the knee area, because nerves like the femoral and obturator nerves supply sensory branches to both joints and the muscles acting on them and the skin over them. Understanding Hilton's Law helps clinicians trace symptoms back to the likely source, even when the pain is felt some distance away.
A very practical law. Finally, the text touches briefly on clinical conditions affecting joints, primarily the wear and tear issue.
Right. The most common joint problem worldwide is probably degenerative joint disease, DJD, often referred to as osteoarthritis. This essentially results from the cumulative effects of aging and mechanical wear and tear on the articular cartilages over many years, especially in weight-bearing joints or joints subjected to heavy use or previous injury.
So the cartilage just wears down.
Pretty much. The normally smooth, resilient articular cartilage gradually softens, roughens, flakes off, fibrillation, and eventually wears thin, sometimes down to the underlying bone. This leads to joint stiffness, aching pain, especially after activity, and reduced range of motion. It's important to realize, as the text notes, that some degree of cartilage degeneration is a normal part of aging, starting relatively early in adult life and progressing slowly. When it becomes symptomatic and severe, we call it osteoarthritis.
And the main diagnostic tool for looking inside a joint.
Besides imaging like X-rays or MRI, arthroscopy is a key clinical procedure mentioned in the final clinical box on page 130. As we discussed earlier with endoscopy, this involves inserting a small telescope, arthroscope, into the joint cavity through a small incision. It allows direct visualization of the internal structures, articular cartilage, ligaments, menisci, synovial membrane for diagnosis, for example, finding the source of pain or locking, and often allows for simultaneous surgical repair of certain problems like torn ligaments or menisci through additional small portals. Minimally invasive and very informative.
Okay, wow. We have just completed an incredibly intensive deep dive into the absolute bedrock, the fundamental language and concepts of anatomical study.
We really covered the gamut, didn't we? We moved systematically, establishing that essential global language, ditching the colloquialisms like armpit for the precise axillary fossa, collarbone for clavicle. We defined that non-negotiable anatomical position as our universal reference.
And we detailed the 3 critical ways to approach the body. The layer-by-layer regional view, so important for dissection, the functional systemic view, grouping by organ systems, and that crucial invoted problem-solving clinical view, working backwards from symptoms.
Exactly. We then wrap the body, looking at the complex functions of the skin, the integumentary system protection, containment, sensation, vitamin D, thermal regulation. We learn the critical importance of tension lines for surgical incisions to minimize scarring, and the 4 classifications of burn severity, plus the rule of 9s for assessment.
We also saw how the seemingly simple deep fascia is crucial, forming compartments and enabling the vital musculovenous pump through its unyielding nature. And we used that great fist in a balloon analogy to understand friction-reducing bursae and the serous sacs surrounding our mobile organs.
And then we laid down the framework itself, the skeleton, differentiating axial from appendicular, cartilage from bone. We classified bones by shape: long, short, flat, irregular, sesamoid. We deciphered bone markings. Critically, we understood bone as a living tissue growing via endochondral ossification at epiphyseal plates, remodeling constantly, and subject to clinical issues like fractures, osteoporosis, and avascular necrosis.
And we emphasized that crucial clinical distinction between a pediatric growth plate injury and an adult-type fracture, Finally, we survey the entire spectrum of joints, or articulations, from immovable fibrous sutures to slightly movable cartilaginous symphyses, all the way to the highly mobile synovial joints, which we broke down into those 6 functional types: plane, hinge, saddle, condyloid, ball and socket, and pivot, all connected by the wisdom of Hilton's law relating nerve supply.
It's a massive foundation we've built. But connecting this back to the bigger picture, this entire framework, the terminology, the planes, the typical structures, it all relies on this concept of the idealized average anatomical model, the
Right.
textbook human.
The standard.
And yet, we spent time emphasizing that anatomical variations are not just possible, they're common. We noted veins vary the most, nerves the least. We saw that around 3% of newborns have significant congenital anomalies. We know that clinical awareness of potential variations, like in the course of that critical cystic artery during gallbladder surgery, is what elevates basic anatomical knowledge from just an academic exercise into the true art of clinical practice and safe surgery.
So here's maybe the provocative thought to leave you, our learner, with today. We've just spent all this time meticulously defining the normal, the idealized body, based on Moores. But we also acknowledge the reality that variation is the norm, not really the exception. How does truly accepting variation as fundamental, rather than just an occasional oddity, change the way you approach diagnosing and treating the unique individual human body in front of you? Does it demand a constant state of questioning, of looking beyond the textbook average, even when faced with seemingly straightforward symptoms? Perhaps that awareness, that willingness to consider the possibility of variation in every single case, is actually your most powerful diagnostic and therapeutic tool moving forward.
A very important consideration indeed. Well, thank you for joining us for this foundational deep dive into the language and basic structures of human anatomy based on Moore's Chapter 1. We certainly look forward to seeing you for the next one. Welcome back to Bookfulness. This is episode 2 in our deep dive into Moore's Clinically Oriented Anatomy, 9th edition.
Hello again. Yeah, in our first session, we really laid down the anatomical alphabet, the planes, positions, and we built the body's framework.
Yeah.
The skin, the bones, everything that contains and supports.
We definitely set the stage, and now we're moving into the dynamic parts, what makes the body do things.
Right.
We're going beyond that static structure to the systems for action, transport, and control. So today it's the muscular, cardiovascular, lymphoid, and nervous systems. We're looking at pages 131 to 178 in Chapter 1.
And this is where I think the clinically oriented part of the title really starts to shine.
Yeah.
Because for anyone going into healthcare, well, just memorizing names of muscles or bones isn't enough, is it?
Not at all.
You have to grasp the function, how these systems work normally, how they react under stress, and crucially, how a problem in one system shows up as a symptom somewhere else. We're shifting from just structure to, well, mechanism, dynamic physiology.
Okay, let's jump right in with the system for movement, the muscular system. The text kicks off by outlining 3 basic types of muscle tissue. Table 1.1 gives a great summary of their differences.
Yeah, 3 very distinct types doing different jobs. First up is skeletal striated muscle. This is the stuff you control consciously.
Our voluntary muscles.
Exactly. Think biceps, quads, all of those. It's known for strong, rapid contractions.
Yeah.
And striated just refers to that striped look you see under a microscope, which comes from how the contractile proteins are arranged. Very organized.
Then there's cardiac striated muscle. It looks similar, striped, but the control is totally different.
Right. It's involuntary. You find it only in the heart wall, the myocardium, and just a little bit extending into the walls of the big vessels connected to the heart, like the aorta and pulmonary vein.
And that involuntary control is fascinating. It's not directly run by your conscious thought.
No, the heart has its own internal pacemaker system, a specialized conducting system that sets the basic rhythm. The autonomic nervous system, which we'll get to later, can speed it up or slow it down, adjust the force, but the fundamental beat comes from within the heart itself. It just has to keep going.
Okay, and the third type is smooth muscle. The name kind of gives it away.
It does. No stripes, no striations. It's also involuntary. This is more the infrastructure muscle. It makes up the walls of blood vessels, that middle layer, the tunica media, and the walls of hollow organs.
Like the digestive tract.
Exactly. The gut, the bladder, airways, ducts. All lined with smooth muscle to push things along or control diameter. But it also shows up in places you might not expect, like those tiny erector muscles attached to hair follicles that make your hair stand on end.
Goosebumps.
That's smooth muscle. And also in the eye, controlling your pupil size and lens shape. So it's quite versatile, just operates behind the scenes.
So focusing back on skeletal muscle, the ones we see and feel, they have the main contractile part, the belly, which is usually reddish and fleshy. And then they attach to bones via these white, tough, non-contractile bits, tendons or aponeuroses.
Right. Tendons are the cord-like structures, like your Achilles tendon. Aponeuroses are broad, flat sheets of tendon, common in the abdominal wall, for example.
And the shape, the architecture of that muscle belly is really important for its function, isn't it? Figure 1.18 shows a few different types.
Absolutely. Form dictates function here. A flat muscle might blend into an aponeurosis. A fusiform muscle, like the biceps, is spindle-shaped, thick in the middle, tapering at the ends. Good for range of motion and force.
Then you have things like pennate muscles. They look like feathers.
Yeah, the fibers attach obliquely, like the barbs of a feather, onto a central tendon. This packs more fibers into a smaller space, so they're often very powerful, even if the range of motion is less. Think deltoid or rectus femoris.
And convergent muscles.
They start broad and narrow down to a single tendon, like pectoralis major. Allows force to be directed to a specific point. Then you have simpler shapes, like quadrate, squarish, circular sphincters, or muscles with multiple heads or bellies, like the biceps or triceps.
Knowing these shapes, plus the naming conventions often based on location or shape, size, attachments, action, it gives you a lot of clues about what the muscle does without even seeing it move.
It really does. It's anatomical shorthand.
Now, when we talk about how a muscle works, the classic terms are origin and insertion. Origin is usually proximal, the fixed point. Insertion is distal, the moving part.
That's a traditional definition, and it works, sometimes. But the book rightly points out it can be misleading. Muscles don't care about definitions. They just pull.
What do you mean?
Well, take your biceps again. When you lift a cup, your forearm insertion moves towards your upper arm origin. That fits the definition. But what about a pull-up?
Ah, okay. Your hands are fixed on the bar, that's the distal part, and your body, the proximal part, moves towards your hands. The origin is moving towards the insertion.
Precisely. The roles reverse, depending on which end is stabilized. So, while origin and insertion are useful starting points, for clinical accuracy, especially in biomechanics, it's often better to just talk about the proximal and distal attachments, or medial and lateral attachments. It avoids ambiguity.
That makes sense. It depends on the context of the movement. Okay, let's talk about the types of muscle contraction. The book outlines 3 main ways skeletal muscles activate: reflexive, tonic, and phasic.
Yeah, and we need all 3 happening constantly. Reflexive contraction is automatic. Think about your diaphragm contracting when you breathe normally. You're not consciously telling it to fire each time.
Or the knee-jerk reflex.
Perfect example. That's a purely reflexive skeletal muscle contraction, triggered by stretching the tendon.
Then there's tonic contraction, or muscle tone. This isn't about movement, right? It's more subtle.
Exactly. It's a slight, constant tension that almost all healthy muscles maintain even when they're at rest. It doesn't produce movement, but it keeps the muscle firm, ready to respond, and critically, it stabilizes joints and helps maintain posture.
So it's like the engine idling.
That's a great analogy. It's that background hum.
Yeah.
And you really notice its importance when it's gone, like under general anesthesia or in paralysis. Joints become unstable, floppy, because that baseline stabilizing tension is lost. A paralyzed limb might assume an odd position simply because the tone is gone.
Interesting. Okay, and the third type is phasic contraction. This is the one we usually think of active muscle work.
Right. This is when the muscle actively contracts to produce movement or resist a force. And phasic contractions are divided into 2 main types, isotonic and isometric.
Okay, break those down.
Isometric means same measure or same length. The muscle generates tension, but it doesn't shorten or lengthen, so no movement occurs at the joint. Think pushing against an immovable wall or just holding a heavy object steady.
You feel the strain, but nothing's moving.
Exactly. Isotonic, on the other hand, means same tension, though that's a bit of a misnomer. The tension can fluctuate. But the key is that the muscle changes length and movement occurs.
And isotonic contraction itself has 2 subtypes, which figure 1.20 illustrates really well. This seems important.
It is absolutely fundamental. We have concentric contraction and agesic contraction.
Concentric is the shortening.
Yes. Concentric is when the muscle generates force and overcomes resistance, causing the muscle to shorten. This is your classic lifting action, curling a dumbbell, standing up from a chair.
And eccentric.
Eccentric is when the muscle is active, generating tension, but it's lengthening because the external force is greater than the force the muscle is producing. It's a controlled yielding or braking action.
So lowering the dumbbell slowly Or sitting down gently into the chair.
Precisely. You're actively controlling the descent against gravity, using the same muscles that lifted you up, but now they're lengthening.
Why is making this distinction between shortening and controlled lengthening so vital?
Several reasons. First, coordination. Almost all smooth, coordinated movements involve a mix of concentric and eccentric contractions. Walking, running, throwing, they all rely on eccentric braking. Second, force production. Eccentric contractions can actually generate more tension, up to 50% more than maximal concentric contractions.
Wow, really? So you're stronger lowering a weight than lifting it?
Potentially, yes. In terms of the tension the muscle can withstand and control eccentrically. This is why eccentric training is so effective for building strength and resilience. It's also why muscles are often injured doing eccentric actions. They're handling very high forces while lengthening.
That leads into the next section about muscle function and how muscles work together. It's not just one muscle doing everything.
Never. Movement is always a team effort. The book describes 4 main functional roles.
Okay, what are they?
First, the prime mover, or agonist. This is the main muscle, or group of muscles, responsible for producing a specific movement. It contracts concentrically.
Like the biceps during an arm curl.
Exactly. Then you have the fixator. Fixators contract isometrically. They don't produce movement themselves, but they stabilize the origin of the prime mover, or stabilize a body part, so the prime mover can work efficiently.
So like the muscles around your shoulder blade holding it steady while your arm moves?
Perfect example. Without those fixators, the force from your arm muscles would just wiggle your shoulder blade around instead of moving your arm effectively.
Okay, third role.
The synergist. Synergists help the prime mover. They might contribute a bit to the same movement, or they might cancel out an unwanted secondary action of the prime mover. For instance, some wrist muscles act as synergists during fist clenching to prevent the wrist from bending at the same time.
They fine-tune the movement.
Yeah, or stabilize an intermediate joint if the prime mover crosses more than one joint.
And the last one is the antagonist.
The antagonist is the muscle that opposes the action of the prime mover. When the prime mover contracts concentrically, the antagonist typically relaxes progressively, but often it also contracts eccentrically to control the speed and smoothness of the movement, acting as a brake.
Like the triceps during that biceps curl, controlling how fast you flex your elbow.
Precisely. Agonist and antagonist pairs work together constantly.
The text mentions shunt versus spurt muscles. Are these distinct types or related to these roles?
They relate more to the mechanics of how a muscle attaches and pulls, which influences its primary role. It's about leverage. A spurt muscle attaches further away from the joint it moves,
giving it better leverage for rotation.
Exactly. Its line of pull creates a strong turning force. These are often your prime movers. A shunt muscle attaches very close to the joint. Its line of pull is more parallel to the bone it's moving.
So it's pulling along the bone towards the joint.
Right. This means it's very effective at stabilizing the joint, pulling the bones together, and resisting dislocation forces. Shunt muscles are often important fixators. Many muscles, like the brachialis in the arm, effectively act as both, contributing to movement and stability. It's about the geometry of the attachment.
Okay, that clarifies things. Now, how do these muscles get their instructions and fuel? Neurovascular supply. The book highlights a key difference between nerve and artery supply.
Yeah, this is a really practical point. Nerve supply to muscles is remarkably consistent. Generally, muscles in the same functional compartment doing similar jobs are innervated by the same nerve or nerves.
Makes learning them easier.
It does. You learn the nerve, you know the muscles it controls. Also, crucially, motor nerves tend to enter the muscle on its deep surface, in the fleshy part, away from harm. It's a protective design.
But the blood supply, the arteries, are less predictable.
Much less predictable. Arterial supply is often from multiple sources, and the specific arteries involved can vary quite a bit between individuals. You generally figure out which artery supplies a muscle based on proximity. Whatever major artery runs nearby is likely sending branches to it.
So less strict rules for arteries.
Fewer strict rules, more redundancy often. This variability sometimes allows surgeons to tie off an artery without killing the muscle, because other arteries might provide enough collateral flow. We'll touch on that more with the cardiovascular system.
All right, let's hit the clinical correlates for skeletal muscles, pages 140, 142. First up is muscle testing.
Essential clinical skill. It's how you assess the integrity of the nerve supply to a muscle. You typically ask the patient to perform the muscle's action against your resistance, or you try to move their limb while asking them to resist.
And you're grading the strength.
Exactly. You grade the power, usually on a standard scale. Weakness in a specific muscle or group points towards a potential nerve lesion at a particular level.
And if there is nerve damage leading to muscle dysfunction and paralysis,
Then you see atrophy, the muscle wastes away. This can happen from disuse, like being in a cast, but denervation, atrophy, loss of nerve supply, is particularly severe.
and this goes back to the idea of thinking about loss of function.
Yes. Don't just think biceps flexes elbow. Think if the nerve to the biceps is cut, the patient cannot strongly flex their elbow, and the elbow might hang in a slightly extended position at rest. Why?
Because the antagonist, the triceps, still has its normal muscle tone.
Precisely. The unopposed tonic pull of the healthy antagonist muscle pulls the joint into an abnormal resting posture. This is a key diagnostic clue. Loss of function and change in resting position due to loss of tone.
Okay, what about common injuries like muscle soreness or a pulled muscle? Figure B1.8 shows a hamstring tear. Why are muscles vulnerable to this?
It comes down to physics and biology. Muscle fibers have a limit to how far they can stretch. They can't safely elongate much beyond about 1/3 of their resting length. Usually, your joints and ligaments stop you before you reach that point.
But not always.
Not always, especially with muscles that cross two joints, like the hamstrings. They cross both the hip and the knee. If you try to touch your toes with your knees straight, you're maximally lengthening the hamstrings at both ends.
I could feel that.
Right. Now imagine doing that forcefully or quickly, especially during an eccentric contraction where the muscle is already under high tension trying to control movement like sprinting or landing from a jump. The forces can exceed the tissue's limit, causing fibers to tear. That's your pulled muscle or strain. Hamstrings are notorious for this.
Ouch. Okay, last clinical point here. Muscle growth and regeneration. When bodybuilders get huge, are they making new muscle cells?
No, not really. Skeletal muscle fibers themselves don't divide. The increase in muscle size from exercise is hypertrophy. The existing individual muscle fibers get bigger, thicker, by adding more contractile proteins, myofibrils, inside.
So bigger cells, not more cells.
Correct. There are some precursor cells, called satellite cells, nestled alongside the muscle fibers that can help with minor repair and limited regeneration, but they can't replace large amounts of damaged muscle. Significant injury usually results in fibrous scar tissue forming, which isn't contractile.
So skeletal muscle is good at getting bigger, but not great at repairing major damage.
That's a fair summary.
All right, let's quickly revisit the other muscle types before moving to transport systems. Cardiac muscle.
Right, the heart muscle. Clinically, a key concept is its incredible metabolic demand. It never stops working, so it needs a constant, rich blood supply, about twice as much blood flow per gram as active skeletal muscle.
Which is why blockages in coronary arteries are so dangerous, leading to myocardial infarction, heart attack, tissue death.
Exactly. The heart muscle can also undergo hypertrophy, getting thicker in response to chronic high pressure, like hypertension. But like skeletal muscle, the cells can't divide, so there's a limit to this compensation.
And smooth muscle. What's key clinically there?
The big difference is its regenerative capacity. Smooth muscle cells can undergo hyperplasia, meaning they can divide and increase in number. They also undergo hypertrophy.
So they can adapt more.
Yes, think about the uterus. During pregnancy, it grows massively through both hypertrophy and hyperplasia of its smooth muscle layers, or blood vessels thickening their walls in response to chronic high blood pressure. This ability to increase both cell size and cell number gives smooth muscle tissues greater adaptive potential than striated muscle.
Got it. Okay, let's shift gears now to the transport highways. The cardiovascular system, pages 144 to 154. Figure 1.22 gives that nice overview of the two circuits.
Yeah, the two-pump system. The right side of the heart pumps blood low in oxygen to the lungs as the pulmonary circulation gets oxygenated there,
Then it comes back to the left side.
which pumps the freshly oxygenated blood out to the rest of the body, the systemic circulation.
And figure 1.22c makes a really important point. The systemic circulation isn't just one big loop after the lungs.
No, that's crucial. It branches into many parallel circuits. Blood goes simultaneously to the brain, the kidneys, the gut, the limbs, each through its own dedicated arterial branches off the main trunk, the aorta.
Why is that parallel setup important?
It allows for independent regulation of blood flow. Your body can send more blood to your digestive system after a meal without necessarily starving your brain, or direct more flow to your muscles during exercise. If it were all one series circuit, flow changes in one area would affect everything downstream.
Makes sense. Okay, the vessels themselves, arteries, veins, capillaries, most have that three-layer wall structure, the tunics, shown in figure 1.23.
Right. Innermost is the tunica intima, a thin layer of endothelial cells lining the lumen, plus a bit of connective tissue. Very smooth surface for blood flow. Capillaries are basically just this layer.
Middle layer.
Tunica media. This is mainly smooth muscle and elastic fibers. It's the thickest layer in arteries and the most variable layer overall. Contraction or relaxation of this smooth muscle changes the vessel diameter, controlling blood flow and pressure.
And the outer layer.
Tunica adventitia. This is the tough outer connective tissue coat. It anchors a vessel and contains nerves and, in larger vessels, tiny blood vessels, vasa vasorum, that supply the wall itself.
And the main difference between arteries and veins is the thickness of these layers, especially the media.
Generally, yes. Arteries handle high pressure, so they have thicker, more muscular and elastic walls than veins. Veins handle low pressure, so their walls are thinner, and their lumens, the internal channel, are often wider.
Looking closer at arteries, figure 1.24, they range from huge elastic ones near the heart to tiny arterioles.
Exactly. Large elastic arteries, like the aorta, absorb the pressure pulse from the heartbeat, smoothing out blood flow. Medium muscular arteries distribute blood to different body regions. Their thick tunica media allows them to actively regulate flow. Small arteries and arterioles are the main resistance vessels, controlling blood pressure and flow into the capillary beds where exchange happens.
A key concept for arteries is redundancy backup routes, collateral circulation.
Very important. This refers to alternative pathways, or anastomosis, where branches of different arteries connect. If one pathway gets slowly blocked, these connections can enlarge over time and provide blood flow around the blockage.
Like detours on a highway.
Good analogy. They're especially common around joints, where movement might temporarily pinch off a main artery.
But you mentioned slowly blocked. What if it's sudden?
That's the catch. These collateral pathways need time, days or weeks, to enlarge enough to handle the full blood flow. If a major artery is blocked suddenly, like by a blood clot, embolus, the existing collaterals are usually too small to compensate immediately. That leads to ischemia, lack of blood flow, and potentially infarction tissue death.
Which brings us to terminal arteries.
Right. Some arteries have no significant anastomosis. These are true terminal arteries. Block one, and the tissue it supplies will die. The artery supplying the retina is a classic example.
Blindness if it's blocked.
Instantly. Then there are functional terminal arteries. These might have tiny anastomoses, but they're insufficient to prevent infarction if the main artery is blocked suddenly. This applies to critical areas like segments of the heart, brain, kidneys, liver, and spleen. Blockage here is still usually catastrophic.
Okay, switching to the veins, they're generally more numerous and variable than arteries.
Yes, and they hold a lot more blood, maybe 80% of your total blood volume at rest. They're the capacitance vessels. Because the pressure is low, especially in the limbs fighting gravity, they need help getting blood back to the heart.
That's where venous valves come in.
Absolutely crucial in medium veins, particularly in the limbs. They're passive flaps, cusps of the tunica intima, that break the column of blood into segments and ensure flow only goes towards the heart. They prevent backflow.
We also often see veins traveling right alongside arteries, especially deep in the limbs. Vena combatantes, figure 1.25.
Yes, accompanying veins. Often paired, sometimes more, wrapped in the same connective tissue sheath as the artery. This close proximity is key for the musculovenous pump.
Ah, the mechanism that helps push blood uphill? How does that work?
It's elegant. You have these deep veins nestled amongst skeletal muscles. These muscles are contained within compartments defined by tough, inelastic, deep fascia.
Like wearing tight compression socks, but built in.
Kind of. When you contract those muscles, like walking or clenching your calf, the muscles bulge but can't expand outwards much because of the fascia, so they squeeze the deep veins running between them.
Milking the blood upwards.
Exactly. And the venous valves prevent it from falling back down when the muscles relax. It's incredibly effective. That's why moving around is so important for circulation, especially preventing clots in the legs. If you stand still for too long, the pump isn't working and blood pools.
And briefly, capillaries, the exchange sites.
Tiny, thin-walled vessels, just the tunica endothelium. Their walls are permeable, allowing oxygen, nutrients, waste products, hormones, etc., to exchange between the blood and the surrounding tissue fluid, interstitial fluid. They form vast networks called capillary beds.
Okay, clinical issues here. Arteriosclerosis is the general hardening of arteries.
Right, loss of elasticity. The most common and important form is atherosclerosis, shown in figure B1.9. This is where fatty plaques atheromas build up within the tunica intima.
What's the danger there?
Two main problems. The plaque narrows the lumen, restricting blood flow and increasing pressure. More critically, the plaque surface is rough and prone to ulceration, which can trigger formation of a blood clot, thrombus right there, potentially blocking the vessel completely. Or a piece of the plaque or clot can break off and travel downstream, embolus, and block a smaller vessel.
Leading to ischemia and infarction, heart attack, stroke, gangrene in limbs.
Exactly. And for veins, the common clinical issue is varicose veins, figure B 1.0. This happens when the venous valves fail, usually in superficial veins where there's less external support. Blood flows backward, refluxes and pools, causing the veins to become dilated, tortuous, and elongated. It's often cosmetic, but can lead to pain, swelling, and skin changes due to chronic venous insufficiency, failure of those one-way valves.
Okay, moving from blood transport to fluid drainage and defense. The lymphoid system, pages 154, 159. What's its main job?
Its primary role is collecting the excess fluid, proteins, and other stuff that leaks out of blood capillaries into the tissue spaces. This fluid is called lymph, and returning it to the bloodstream. It's like a parallel drainage system, essential for fluid balance.
And it has other roles too.
Yes, it's crucial for absorbing digested fats from the intestine, which are too large to enter blood capillaries directly, and transporting them to the blood. And critically, it's a major part of the immune system.
What are the components? Figure 1.27 shows the overall layout.
It starts with blind-ended lymphatic plexuses, capillary networks, in the tissues. These drain into larger lymphatic vessels. Along the way, these vessels pass through lymph nodes, small bean-shaped structures packed with lymphocytes and other immune cells.
The nodes act as filters.
Exactly. They filter the lymph, trapping pathogens, cell debris, and even cancer cells. The filtered lymph continues through larger vessels and eventually drains back into the large veins near the heart. There are also specialized lymphoid organs like the spleen, thymus, tonsils.
Where does all this lymph fluid end up?
Most of it from both legs, the abdomen, the left chest, left arm, and left side of the head and neck, collects into the largest lymphatic vessel, the thoracic duct. This big duct ascends through the thorax and empties into the venous system at the junction of the left internal jugular and left subclavian veins, the left venous angle.
Only the upper right part of the body drains differently.
Right. The right arm, right chest, and right side of the head and neck drain via a smaller right lymphatic duct into the right venous angle. Knowing these drainage territories is vital for understanding how infections or cancers might spread.
Which brings us straight to the clinical relevance, especially metastasis, the spread of cancer. Pages 157 to 159.
Hugely important. Lymphatic vessels are the most common initial pathway for the spread of carcinomas, which are cancers arising from epithelial tissues like skin, glands, lining of organs. Cancer cells can break off the primary tumor, invade nearby lymphatic vessels, get carried along with the lymph flow, and then get trapped in the first lymph node they encounter.
And that node becomes a secondary tumor site.
Yes,
Yeah.
potentially. This is why surgeons often remove or biopsy regional lymph nodes, sentinel nodes, when treating carcinomas to check if the cancer has started to spread.
What about other cancer types like sarcomas?
Sarcomas cancers of connective tissues like bone or muscle behave differently. They tend to spread via the blood, particularly the veins. This is called hematogenous spread.
Why veins?
Veins are more numerous, have thinner walls, and lower pressure than arteries, making them easier for cancer cells to invade. Venous blood from most of the body eventually flows through the liver and the lungs.
So the liver and lungs are common sites for secondary sarcoma tumors?
Very common. Understanding these different patterns of spread lymphatic for carcinomas, hematogenous for sarcomas, is fundamental to cancer staging and treatment planning. The text also mentions lymphangitis, inflammation of lymph vessels, often seen as red streaks under the skin during infection, and lymphedema, swelling due to impaired lymphatic drainage.
Okay, powerful systems for transport and defense. Now, let's move to the ultimate control network. The nervous system, starting on page 159. Big topic.
Huge. We break it down structurally and functionally. Structurally, you have the central nervous system, CNS, the brain and spinal cord, the integration and command center, and the peripheral nervous system, PNS, everything else. The nerves connecting the CNS to the rest of the body plus associated ganglia.
And functionally?
Functionally, we divide it into the somatic nervous system, which handles voluntary control of skeletal muscles and conscious sensory perception, touch, pain, temperature, etc. And the autonomic nervous system, ANS, which manages involuntary functions, smooth muscle, cardiac muscle, glands. Think digestion, heart rate, sweating.
The basic cells are neurons and neuroglia.
Right. Neurons, figure 1.28, are the communication specialists. You have different types, like multipolar motor neurons carrying commands out from the CNS, and pseudo-unipolar sensory neurons bringing information in. They communicate chemically across junctions called synapses, figure 1.29.
And the neuroglia.
Glial cells. These are the support staff non-neuronal cells that outnumber neurons. They provide physical support, insulation, myelin, nourishment, defense, and maintain the chemical environment for the neurons. Essential, but not directly involved in transmitting the signals over long distances.
Inside the CNS brain and spinal cord, we use specific terms for structures.
Yes. A collection of neuron cell bodies within the CNS is called a nucleus. A bundle of nerve fibers, axons, connecting different nuclei within the CNS is called a tract.
And the tissue itself looks different gray and white matter, figures 1.3, 1.31.
Correct. Gray matter is where the neuron cell bodies, dendrites, unmyelinated axons, and synapses are concentrated. It's the processing occurs. In the spinal cord, it's deep in an H shape. In the brain, it's mostly on the surface, cerebral cortex, and in deep nuclei. White matter consists primarily of myelinated axons, those tracks we mentioned. The fatty myelin sheath gives it the white appearance. It's the wiring transmitting signals between gray matter areas.
Okay, now moving out to the PNS, what are the equivalent terms?
A collection of neuron cell bodies outside the CNS is called a ganglion, plural, ganglia, and a bundle of nerve fibers, axons outside the CNS, is simply called a nerve.
And nerves need protection, especially as they run through limbs that move. The book uses that telephone cable analogy for the connective tissue layers, figures 1.32, 1.33.
It's a great analogy. Each individual nerve fiber, axon, possibly with its myelin sheath, is wrapped in a delicate layer called the endoneurium.
Like the insulation on a single wire.
Exactly. Then, groups of these fibers are bundled together into fascicles, and each fascicle is wrapped in a tougher, denser layer called the perineurium. This layer is really important. It acts as a barrier, controlling what substances can reach the nerve fibers.
Kind of like the sheath around a bundle of wires inside the main cable.
Perfect. And finally, the entire nerve, all the fascicles bundled together, along with blood vessels supplying the nerve, is encased in the thick, tough outer layer, the epineurium. This provides structural integrity and cushioning. These layers give nerves their tensile strength and resilience.
All right, structure of a nerve sorted.
Yeah.
How is the PNS organized overall? We have cranial nerves and spinal nerves.
Right. Cranial nerves emerge from the brain, 12 pairs. Spinal nerves emerge from the spinal cord, 31 pairs. Each spinal nerve, figure 1.34, is formed by the union of two roots attaching to the spinal cord. A posterior dorsal root, which carries sensory information in, and has a ganglion, the spinal ganglion or dorsal root ganglion, containing the sensory neuron cell bodies, and an anterior ventral root, which carries motor commands out.
Sensory in the back, motor in the front.
Generally speaking, yes. These two roots join just outside the spinal column to form the mixed spinal nerve, carrying both sensory and motor fibers.
This spinal nerve setup leads to the concept of segmental innervation, dermatomes, and myotomes.
Absolutely key for clinical diagnosis, because each spinal nerve develops in association with a specific body segment, such as might, during embryonic development, figure 1.35, it retains a connection to that segment. A dermatome, figure 1.36, is the specific area of skin supplied by the sensory fibers from a single spinal nerve.
So numbness or tingling in a specific pattern on the skin can point you to which spinal nerve or cord level is affected.
Precisely. The dermatome map is a clinical roadmap. The motor equivalent is the myotome. That's the group of muscles primarily innervated by the motor fibers from a single spinal nerve root or spinal cord segment. Testing muscle strength in different groups helps pinpoint motor nerve lesions.
Okay, so the spinal nerve forms carry sensory and motor info for its segment. Then what happens? It splits again.
Yes. Almost immediately after exiting the intervertebral foramen, the spinal nerve divides into two main branches, or ramus, figures 1.37 to 1.4. There's a smaller posterior dorsal ramus and a much larger anterior ventral ramus.
Do they supply different areas?
Completely different territories. The posterior rami turn backwards and supply only a narrow strip. The deep intrinsic muscles of the back, the joints of the vertebral column, and the skin directly overlying them. They follow a simple segmental pattern down the back.
And the larger anterior rami?
They supply everything else, the muscles and skin of the limbs, and the anterior and lateral trunk. In the thoracic region, T2, T11, 12, they mostly remain segmental too, running between the ribs as the intercostal nerves.
But elsewhere, they do something more complicated.
Yes. In the cervical, lumbar, and sacral regions, the anterior rami don't stay separate. They merge, braid together, exchange fibers, and form complex networks called plexuses, like the brachial plexus for the arm or the lumbosacral plexus for the leg.
Why form these tangled plexuses?
It allows nerve fibers originating from multiple spinal cord segments to combine and be redistributed into new peripheral nerves that supply specific parts of the limb. It means that most limb muscles receive innervation from more than one spinal segment, and most peripheral nerves contain fibers from multiple segments.
So damage to a single spinal nerve root doesn't completely paralyze a limb muscle?
Usually not completely, no. It provides redundancy and ensures coordinated innervation of complex limb structures. It's a clever bit of wiring.
Okay, one more layer of classification. The type of information the nerve fibers carry. Somatic versus visceral, figures 1.41, 1.42.
Right. We can categorize fibers based on what they connect to and the type of information. 1. General sensory fibers, general somatic afferent GSA, carry touch, pain, temperature, pressure, proprioception, sense of position, from skin, muscles, tendons, joints, conscious sensation. 2. Somatic motor fibers, general somatic afferent GSE, carry commands to skeletal muscles, voluntary movement. 3. Visceral sensory fibers, general visceral afferent GVA, carry sensory information from internal organs, glands, blood vessels, mostly subconscious, like blood pressure monitoring, but can include visceral pain like cramps or angina, often poorly localized or referred. 4. Visceral motor fibers, general visceral efferent GVE. These are the fibers of the autonomic nervous system. They carry commands to smooth muscle, cardiac muscle, and glands. Involuntary control.
Understanding these fiber types within a given nerve helps predict the effects of nerve damage.
Absolutely. A nerve lesion might affect only motor function, only sensation, or a combination, depending on the fibers involved.
Okay, let's dive into that last category, the visceral motor system, aka the autonomic nervous system, ANS. Pages 170, 178. You said this controls involuntary stuff.
Right. Heart rate, digestion, sweating, pupil size, all the automatic background processes. The most fundamental difference between how the ANS controls its targets and how the somatic system controls skeletal muscle is the two-neuron chain, figure 1.42.
Explain that. Somatic motor is just one neuron from CNS to muscle.
Yes. A single motor neuron sits in the spinal cord or brainstem. Its axon travels all the way out in the nerve and synapses directly onto the skeletal muscle fiber. Simple, direct connection.
But the ANS uses two.
Always two neurons in sequence to get the message from the CNS to the target organ, smooth muscle, cardiac muscle, or gland. Neuron #1 is the presynaptic or preganglionic neuron. Its cell body is in the gray matter of the CNS, brainstem or spinal cord. Its axon leaves the CNS.
But doesn't reach the target.
No. It travels out to an autonomic ganglion, one of those collections of nerve cell bodies outside the CNS, and synapses there onto neuron #2.
And neuron #2 is?
Neuron #2 is the postsynaptic or postganglionic neuron. Its cell body is in that autonomic ganglion. Its axon then travels the rest of the way to the actual effector organ, heart, gut wall, sweat gland, etc., and synapses there.
So CNS, presynaptic neuron, autonomic ganglion, postsynaptic neuron, target organ, that two-step relay is universal for the ANS.
Universal. Now, the ANS itself has two main divisions that often have opposing effects: sympathetic and parasympathetic. Let's tackle the sympathetic division first. It's often called the thoracolumbar division.
Why thoracolumbar?
Because the cell bodies of all the presynaptic sympathetic neurons are located only in the spinal cord segments between T1 and L2 or L3. That specific region, the intermediolateral cell columns, IMLs, of the thoracic and upper lumbar cord, is the sole origin for the entire sympathetic outflow.
That seems very limited. How does it manage to affect the whole body, head, feet, everything?
Through clever distribution and amplification. First, the axons of these presynaptic neurons leave the spinal cord via the anterior roots and enter the sympathetic trunks, or chains. These are two chains of interconnected ganglia running vertically along either side of the vertebral column, extending all the way up the neck and down into the pelvis.
So the presynaptic fibers travel to these trunks. Then what?
Once a presynaptic fiber enters the sympathetic trunk via a connecting branch called a white ramus communicans, it has several options, which explains the wide distribution. 1, it can synapse immediately with a postsynaptic neuron in the ganglion at that same level. 2, it can ascend or descend within the trunk to synapse in a ganglion at a higher or lower level. This allows T1 fibers to ultimately control structures in the head and L2 fibers to control structures in the feet. 3, it can pass straight through the sympathetic trunk ganglion without synapsing. These fibers form splanchnic nerves that travel to synapse later in pervertebral ganglia, located out in the abdomen and pelvis, near the major arteries supplying the gut and pelvic organs. These control viscera. 4, rarely some pass through both sets of ganglia to directly stimulate the adrenal medulla, causing hormone release adrenaline.
Okay, so the presynaptic fibers can travel up, down, or straight through the trunk ganglia. But how did the postsynaptic fibers, the ones starting in the trunk ganglia, get out to places like sweat glands in the skin or blood vessels in the limbs? They need to join the regular spinal nerves, right?
Exactly. And they do this via another set of connecting branches called Gray-Rami communicantes. These connect the sympathetic trunk ganglia back to the spinal nerves. Critically, Gray-Rami connect to all 31 pairs of spinal nerves.
Ah, so every spinal nerve receives postsynaptic sympathetic fibers.
Yes. Those postsynaptic fibers then travel out within both the anterior and posterior rami of the spinal nerves, distributing sympathetic innervation to blood vessels, vasoconstriction, sweat glands, sweating, and erector pili muscles, goosebumps, throughout the entire body, wall, and limbs.
That's the key to its widespread reach. Centralized origin, T1L2, distribution up and down the trunks, and then hopping onto all spinal nerves via Gray-Rami.
You got it. Plus, there's that neural proliferation or divergence. The text mentions one presynaptic fiber often synapses with 30 or more postsynaptic neurons. This allows for a very diffuse, widespread response. The classic fight-or-flight response activates many systems simultaneously.
Makes sense. So if sympathetic is T1L2 origin, widespread fight or flight, what about the parasympathetic division?
The parasympathetic is the rest and digest system. Its origin is craniosacral.
Meaning?
The presynaptic neuron cell bodies are located in only two places: specific nuclei in the brainstem, associated with cranial nerves the 3rd, 7, 9, and especially X, the vagus nerve, and in the gray matter of the sacral spinal cord segments, S2, S3, and S4.
So head and tail end, skipping the middle, thorax, and lumbar regions.
Exactly, and its anatomical setup is very different, leading to a different kind of control. It still uses the two-neuron chain, but the presynaptic fibers are very long.
They travel further.
Much further. The presynaptic parasympathetic fiber travels almost all the way to the target organ it's going to control. The synapse with the postsynaptic neuron occurs in a tiny terminal ganglion located either right on the surface of the target organ or actually embedded within its wall.
So the postsynaptic neuron is really short.
Very short, just innervating the local tissue within that organ.
What's the functional consequence of having the synapse right at the target?
It means parasympathetic control is much more discrete and localized. You can activate digestion in the stomach via the vagus nerve without necessarily slowing the heart rate significantly, or constrict the pupil without affecting bladder function. There's very little divergence, usually a 1-to-1 or 1-to-few ratio between pre- and postsynaptic neurons.
So sympathetic, thoracolumbar origin, short preganglionic, long postganglionic fibers synapsing in trunk or prevertebral ganglia, widespread diffuse action via Gray-Rami to all spinal nerves, parasympathetic, craniosacral origin, long preganglionic, short postganglionic fibers, synapsing in terminal ganglia near and target organs, localized discrete action.
That's the perfect summary of the anatomical basis for their different functions.
Fantastic. We've covered an immense amount of ground today, from how muscles contract to how the whole system is wired for transport and communication. Let's try to boil down the absolute must-know takeaways.
Okay. For movement, remember the functional muscle roles: agonist, fixator, synergist, antagonist. And critically, appreciate the difference between concentric, shortening, and eccentric, controlled lengthening contractions. Eccentric is vital for control, shock absorption, and generates high tension.
For transport, think redundancy and critical points. Arterial collateral circulation offers backups but needs time. Terminal arteries, true or functional, leave no room for error if blocked acutely. And the musculovenous pump is that clever mechanical system using muscle contraction, fascia, and valves to drive venous return.
And for communication, structure enables function. Nerves are protected by layers: endo, peri, epineurium. The ANS operates via that two-neuron chain. The sympathetic system achieves its vast reach via the T1L2 origin, sympathetic trunks, and Gray-Rami, distributing fibers to all spinal nerves for diffuse control. The parasympathetic uses its craniosacral origin and terminal ganglia for targeted, localized effects.
As we move forward into specific body regions and mores, this systemic foundation is going to be what you constantly refer back to.
Absolutely. And perhaps the final thought to leave you with is about applying this knowledge clinically. It requires that inversion of thinking we mentioned. Don't just ask, what does this nerve do? Ask, given these symptoms, this pattern of numbness, dermatome, or weakness, myotome, which nerve, root, or pathway must be affected?
And related to that, think about the silent forces. If paralysis knocks out one set of muscles,
the limb doesn't just go limp. It often assumes a characteristic abnormal posture. Why? because of the remaining unopposed tonic contraction of the healthy antagonist muscles. That posture is a direct, visible consequence of the loss of balance in that subtle, continuous background tension that maintains normal joint position. Understanding that underlying tone is pure clinical anatomy in action.
A really powerful point to end on. The body is never truly static.
Never.
Okay, that wraps up this deep dive. Join us next time as we continue our exploration of Moore's clinically oriented anatomy.